Hello and welcome to your ultimate guide for your CMAA exam. My goal today is give you everything that you need to understand the full concepts, master them and walk you through the CMAA exam with total confidence. In this video we will cover downtime procedures, workplace conflict resolution, communication styles, HIPAA OCR enforcement factors, HIPAA transaction standards. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website helps you to practice your CMAA exam with our practice questions, timed mock exams and study guides. You'll find the link in the description below. So let's get started.
Question 1. An EHR outage makes the electronic scheduling module unavailable. The CMAA falls back to a paper appointment book and a runner sheet for new bookings during the outage. Which underlying purpose best fits the practice's documented downtime procedures for scheduling in this kind of unplanned outage scenario? Your options are A. Force every patient to reschedule. B. Cancel future weeks automatically. C. Maintain safe continuous operations. D. Inform marketing about outages. Which one is it? Pause the video if you need more time. The correct answer is C. Maintain safe continuous operations. C is correct because downtime procedures keep the office running safely when the EHR or network is unavailable. Using paper appointment books, runner sheets, and pre-printed daily schedules until the system is restored and data are back entered. A is wrong because downtime procedures do not force every patient to reschedule. They support continued operations through paper alternatives and back entry once systems are restored to working order at the practice. B is wrong because downtime procedures do not cancel future weeks automatically. They support short-term operations during an outage rather than altering long-term scheduling for the practice's calendar going forward. D is wrong because informing marketing about outages is not the underlying purpose of downtime procedures, which focus on safe continuous operations rather than communications with the marketing function at the practice. When an EHR or scheduling system goes offline unexpectedly, a medical office can't afford to freeze. Downtime procedures are the pre-built manual workarounds that keep the front desk running safely until systems are restored. 3 physical artifacts make downtime work. The paper appointment book is kept in a drawer at check-in. A pre-printed daily schedule captures that morning's bookings as a snapshot. A runner sheet records every new appointment, walk-in, or change made while the system is down, including patient name, date of birth, contact number, provider, and reason for visit. Once the system is restored, a designated staff member back enters every line from the runner sheet into the live EHR scheduler and reconciles against the pre-printed schedule to confirm nothing was missed. Downtime procedures are often confused with related concepts. Disaster recovery restores systems and data after a major event. Business continuity is the broader strategic plan. Change management governs planned upgrades. Only downtime procedures address day-to-day front desk operations during an unplanned outage. The underlying purpose of downtime procedures is never to reschedule patients or cancel appointments. It's to keep care moving safely and ensure every paper entry is reconciled back into the live system once it returns. Question 2. A co-worker takes credit during meetings for ideas the CMAA contributed during huddles. The CMAA wants a productive resolution. Which sequence of conflict resolution steps best fits the recommended approach for an interpersonal workplace conflict between 2 members of the same office team here? Your options are A. Address privately, behavior, I statements. B. Address publicly, insult, escalate fast. C. Avoid, ignore, gossip, resign. D. Compete, dominate, demand apology. Take a second. Which answer would you pick? The correct answer is A. Address privately, behavior are statements. A is correct because address it privately and promptly. Focus on behavior rather than personality. Use I statements. Listen. Identify the underlying need. Generate options. Agree on next steps. And follow up later to confirm progress. B is wrong because addressing the issue publicly can humiliate the coworker, escalate the conflict, and undermine the working relationship. Private discussion preserves dignity and allows for an honest exchange focused on actual behavior. C is wrong because avoidance, ignoring, gossip, and resignation neither address the issue nor protect the working relationship. And gossip in particular violates professional conduct expectations that apply to every member of the team. D is wrong because competing and demanding apology focuses on winning rather than resolving the underlying issue and rarely produces sustainable change in behavior between teammates working closely together over time. When interpersonal conflict arises in a medical office, the most effective first-line response isn't avoidance or confrontation. It's a structured private conversation. This approach protects working relationships while actually fixing the problem. Public confrontation humiliates and escalates. Avoidance lets issues fester until someone quits. Demanding apologies focuses on winning, not fixing. All three failure modes are predictable, and all three are avoidable with the right structure. The structured approach unfolds in 6 steps. Request a private conversation. Describe the specific behavior with concrete examples. Name the impact using an ownership statement. Listen without interrupting. Agree on next steps. And schedule a follow-up to confirm the agreement is holding. Together, these elements form a complete cycle. Each step builds trust and moves the conversation from blame toward a shared solution, with the follow-up closing the loop. Don't confuse this first-line approach with formal processes. Grievance procedures and mediation involve HR or a third party. Progressive discipline is manager-driven. The structured private conversation is the correct first response for everyday peer conflict. Formal routes are reserved for when direct resolution fails. Question 3. A patient at the front desk speaks softly, defers repeatedly to a relative, and minimizes her own discomfort by saying it is not a big deal. The CMAA recognizes the communication style and adjusts the approach to match. Which communication style best fits this patient's behavior? Your options are A. Assertive style with clarity. B. Aggressive style dominating. C. Passive-aggressive resistance. D. Passive style with deferral. Before I reveal it, which one do you think is right? The correct answer is D. Passive style with deferral. D is correct because a passive style avoids confrontation, defers to others, and suppresses the speaker's own needs, often through soft speech and minimizing language. The CMAA should ask open questions and allow time for honest responses. A is wrong because an assertive patient communicates clearly and directly while respecting others, which does not match the deferring, minimizing pattern described and would not call for the same kind of supportive coaxing approach. B is wrong because an aggressive patient dominates the interaction, raises voice, or uses absolutes, which is the opposite of the soft and deferring pattern described in this scenario at the registration desk. C is wrong because a passive-aggressive style outwardly agrees while resisting indirectly through sarcasm or silent treatment, while this patient is openly minimizing her own concerns rather than masking quiet resistance to anything. Communication styles describe consistent patterns in how people express needs, handle disagreement, and respond under pressure. Understanding these patterns helps the CMAA respond appropriately at the very first point of contact in the patient journey. The 4 classic styles are assertive, aggressive, passive, and passive-aggressive. Each has a distinct signature. Assertive is direct and respectful. Aggressive dominates and uses absolutes. Passive avoids confrontation and suppresses needs. And passive-aggressive outwardly agrees while resisting indirectly. The passive speaker leaves a recognizable cluster of signals. No single cue proves the style, but together, soft voice, downward gaze, frequent glances at a companion, and minimizing language, they form a pattern the CMAA can learn to spot in real time. Picture a registration desk where a patient defers every question to her adult daughter and quietly says her pain is not a big deal. The CMA who recognizes that pattern can redirect gently, addressing the patient by name, asking open-ended questions, and allowing time so the patient's own voice is heard. Once a passive pattern is recognized, 3 adjustments matter. Ask open-ended questions that invite honest responses, slow the conversation to reduce pressure, and direct questions to the patient herself rather than the accompanying relative. These small moves can surface clinically significant information that minimization would otherwise conceal. Question 4. A patient shouts in the waiting area about a long delay and threatens to leave a viral video review. The CMAA wants to diffuse the situation while protecting other patients in the lobby. Which sequence of actions best fits the recommended approach to handling an irate patient? Your options are: A. Match volume and assert authority. B. Move private, listen, validate, commit. C. Send the patient away immediately. D. Promise refunds without authority. What's your answer? Commit to one before I continue. The correct answer is B. Move private, listen, validate, commit. B is correct because the recommended sequence is to stay calm, move to a private space if possible, listen without interrupting, validate the feeling, apologize for the experience, identify what can be done now, and commit to follow up afterward. A is wrong because matching volume and asserting authority typically escalates the situation, draws the attention of other patients, and damages the relationship rather than de-escalating the immediate issue at the front desk. C is wrong because sending the patient away without effort to address concerns can constitute abandonment risk, harm trust, and ignore the option to resolve the issue with empathy and a clearly stated next step. D is wrong because promising refunds without authority creates expectations that the practice may not honor, undermines billing policy, and can create financial and compliance issues that exceed the CMAA's actual decision-making scope. When a patient becomes irate at the front desk, there is a proven sequence that addresses both their emotional state and the underlying problem, in the right order. Understanding why each step exists helps you apply it reliably, not just memorize it. The sequence starts by removing the audience. A private space cuts the social fuel that often intensifies public anger, then listening without interrupting and validating the feeling, even briefly, releases emotional pressure. Finally, committing to a specific next step restores the patient's sense of agency. Notice that the CMAA moves around the desk. A deliberate step that removes the physical barrier and signals respectful presence. Lowering your own voice triggers an unconscious mirroring response in many people, naturally bringing the patient's volume down with it. Exam questions test whether you can spot counterproductive moves. Matching volume sounds assertive but escalates the situation. Promising refunds or concessions outside your authority creates expectations the practice cannot meet. Every correct answer will include private space, listening, validation, and a committed follow-up within scope. Anger in a public space expresses frustration, demands attention, and signals that normal channels failed. De-escalation works because it honors that function, rather than shutting it down, and then channels the situation toward a real resolution. Question 5. A patient receives a statement from her insurance company explaining how her recent claim was processed. including allowed amount, plan paid amount, and patient responsibility, and clarifying that this is not a bill from the provider. The CMAA recognizes the document. Which document best fits this statement? Your options are A. ICD 10 coding manual, B. OSHA hazard label, C. Explanation of benefits, D. Joint Commission survey letter. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Explanation of benefits. C is correct because the explanation of benefits is the payer's statement to the patient summarizing how a claim was processed, including allowed amount, plan paid amount, patient responsibility, and reason codes, plus the note that it is not a bill. A is wrong because the ICD-10 CM coding manual is a coding reference for assigning diagnosis codes, which is a different document from the patient-facing claim summary described in this scenario at the practice today. B is wrong because an OSHA hazard label appears on chemical containers in workplaces, which is unrelated to a patient-facing claim summary describing how a claim was processed by the insurance company. D is wrong because a Joint Commission survey letter relates to accreditation activities, which is unrelated to the patient-facing claim summary that the patient has received from her insurance company today. The explanation of benefits, or EOB, is the payer's statement to the patient summarizing how a specific claim was processed. It exists to bring transparency between what was billed, what the plan allowed, and what the patient actually owes. The EOB lists key financial fields for every claim: the billed amount, the contracted allowed amount, what the plan paid, any deductible applied, and the patient's remaining responsibility. A clear notice on the document states this is not a bill from the provider. The process begins when the provider's billing team submits a claim to the payer. The payer adjudicates it, applies the contracted allowed amount, and calculates plan payment. The result is both an electronic remittance advice for the provider and an EOB mailed or posted to the patient. Exam questions often test whether you can distinguish the EOB from lookalike documents. The patient statement is the actual bill from the provider. The remittance advice serves the provider's billing team, not the patient. The summary of benefits describes plan coverage in general, while the EOB is claim-specific and patient-facing. When a question stem mentions allowed amount, plan paid, patient responsibility, reason codes, and not a bill together, it is pointing squarely at the EOB, the payer's transparent, claim level summary sent directly to the patient. Question 6. A patient writes that his small intestine is involved in a recent surgery, but the report uses a sound-alike term referring to a pelvic bone. The CMAA must distinguish the two correctly when scanning the operative documents. Which spelling refers specifically to the small intestine portion? Your options are A. ileum, B. ileum, C. ilus, D. ileal. Which would you go with? Lock it in before the reveal. The correct answer is A. ileum. It is correct because ileum spelled with two E's refers to the final portion of the small intestine, while ileum spelled with two E's refers to the upper part of the pelvic bone, which is a frequently confused homophone pair. B is wrong because ileum describes the upper, broad portion of the pelvic bone, not a small intestine segment, so labeling small intestine documentation under that spelling would mislead any reviewer of the operative records. C is wrong because Elias describes a functional obstruction of the bowel, where peristalsis stops temporarily, which is a clinical condition rather than a specific anatomical segment of the small intestine. D is wrong because ileal is an adjective relating to the ilium pelvic bone in some texts, so it points back to the bony pelvis rather than the small intestine segment the patient is asking the assistant. Two terms that sound identical can refer to completely different parts of the body. Understanding the structural and contextual difference between ilium and ileum is essential for accurate medical documentation. The ileum, spelled with two E's, is the final segment of the small intestine, running between the jejunum and the cecum. The ileum, spelled with two R's, is the broad upper portion of the hip bone, forming part of the pelvic ring. The spelling itself is the clue. Ileum shares its E pattern with ileostomy and ileitis, all pointing to the small intestine. Ileum shares its I pattern with iliac crest and iliac artery, all pointing to the pelvis. Context words in the report lock in the correct choice. When a report mentions the cecum, jejunum, or ileocecal valve, the term is ileum. When it mentions the iliac crest, hip, or sacroiliac joint, the term is ileum. These signal words let a CMAA confirm the correct spelling before the document reaches coding. Homophones like ileum and ileum are common exam traps precisely because they sound identical. Pairing careful spelling with surrounding clinical context is the reliable method for catching these errors before they affect coding, billing, or patient care. Question 7. A co-worker outwardly agrees during a meeting to follow a new check-in script, but later misses deadlines, makes pointed sarcastic remarks about the script, and gives the silent treatment when reminded. Which communication style does this overall pattern most clearly illustrate in the team setting? Your options are A. Assertive expression of needs, B. Passive avoidance style, C. Aggressive verbal dominance, D. Passive aggressive resistance. Don't overthink it. Which one feels right? The correct answer is D. Passive-aggressive resistance. D is correct because passive-aggressive communication outwardly agrees while resisting indirectly through sarcasm, silent treatment, or missed deadlines, which erodes trust and stalls problem-solving and is what this co-worker's pattern is showing. A is wrong because an assertive co-worker would name the disagreement directly and respectfully during the meeting rather than agreeing in the moment and resisting later through sarcasm and missed deadlines outside the room. B is wrong because a strictly passive style avoids confrontation but does not include the sarcasm, silent treatment, and pointed remarks that this scenario describes. Passive avoidance is quieter than indirect resistance and undermining behavior. C is wrong because an aggressive style would dominate the meeting with raised voice and direct confrontation rather than agreeing outwardly and resisting later through hidden sarcasm and missed work in this team setting. Passive-aggressive communication is one of the trickiest styles to recognize because on the surface it looks like cooperation. Understanding its defining features helps you spot it and distinguish it clearly from the other three communication styles. The four styles differ in one key dimension: how openly a person expresses resistance. Passive suppresses it entirely, aggressive expresses it loudly, assertive names it respectfully. Passive-aggressive is unique. The person signals agreement but then resists through indirect behavior. The behaviors that flag passive-aggressive style include sarcastic remarks, silent treatment, missed deadlines after agreement, deliberate inefficiency, and pointed comments made just outside the main conversation. Each incident has a cover story, but the cumulative pattern is unmistakable. The defining feature of passive-aggressive style is the gap between surface agreement and underlying behavior. A team member nods in the meeting, says "sounds good," and then ignores the new protocol, making the failure slow, hard to trace, and difficult to hold anyone accountable for. On the exam, when a STEM describes someone who agreed in the meeting but then missed deadlines, made sarcastic comments, or gave the silent treatment, that combination is the unique fingerprint of passive-aggressive communication. No other style pairs surface compliance with covert resistance. Question 8. A patient asks whether her new symptom of mild seasonal sneezing and itchy eyes can be evaluated by telehealth. The CMAA reviews the practice's guidance on telehealth appropriateness for this kind of mild outpatient concern. Which response best fits accepted practice for the scheduling decision in this scenario? Your options are A. Decline and require an inpatient visit. B. Send the patient to the emergency department. C. Telehealth often appropriate for allergic rhinitis. D. Insist on overnight observation. Got a guess? Lock it in. The correct answer is C. Telehealth often appropriate for allergic rhinitis. C is correct because allergic rhinitis is commonly appropriate for telehealth evaluation in a stable, low-risk patient, since the assessment relies on history rather than on hands-on physical examination of internal anatomy structures. A is wrong because an inpatient visit is not warranted for mild seasonal sneezing and itchy eyes, which are stable outpatient concerns that telehealth can typically address through history and patient self-reported observation. B is wrong because the emergency department is not warranted for stable mild allergic rhinitis, which is an outpatient concern rather than an emergency requiring rapid in-person evaluation by emergency medicine staff. D is wrong because overnight observation is reserved for clinically unstable patients rather than stable outpatient allergic rhinitis, so it does not match the appropriate care setting for this presenting complaint at all. Telehealth works best when a clinical concern can be assessed through history alone, without a hands-on physical exam. Understanding which complaints belong in a video visit and which don't is a core scheduling skill for the CMAA. Many outpatient concerns are excellent candidates for telehealth. These include stable allergic rhinitis, chronic condition follow-ups, mental health visits, medication refill discussions, and dermatology questions when a clear photo is available. Key signal phrases guide the decision. Words like stable, mild, history-driven, and recognized pattern point toward telehealth. Phrases like chest pain, severe shortness of breath, or acute trauma point toward in-person or higher acuity care. The CMAA follows a structured screening conversation, gathering the chief complaint, duration, severity, and any red flag symptoms. Then cross-references the practice's documented telehealth guidance to reach a scheduling decision. Telehealth is the synchronous video or phone visit with a clinician. It is distinct from nurse triage, telephone consultations, and remote patient monitoring, three related but separate services the exam may use as distractors. Question 9. A clearinghouse routes claims from providers, validates them, and translates between provider systems and payer-specific formats. The CMAA recognizes the underlying role of the clearinghouse. Which combination best fits the clearinghouse's typical functions at the practice today across both eligibility and claim transmission workflows? Your options are A. Translate, validate, route claims to payers. B. Diagnose, treat, prescribe to patients. C. Schedule, counsel, cook for staff. D. Mop, wax, polish workspace floors. Which one is it? Pause the video if you need more time. The correct answer is A. Translate, validate, route claims to payers. A is correct because clearinghouses translate HIPAA transactions, validate and scrub claims, route claims to payers, manage acknowledgements such as 999 and 277CA, and handle ERA and eligibility transactions across many payer connections. B is wrong because clearinghouses do not diagnose, treat, or prescribe. They are administrative intermediaries that route and validate claims rather than clinical providers serving patients in the practice today. C is wrong because clearinghouses do not schedule, counsel, or cook. They are administrative intermediaries that route and validate claims rather than clinical or operational service providers at the practice today. D is wrong because clearinghouses do not mop, wax, or polish floors. They are administrative intermediaries that route and validate claims rather than facility maintenance providers at the practice during the workday. A clearinghouse is an administrative intermediary that sits between a provider's billing system and the payer's claim system. It is purely an electronic data interchange service. It never diagnoses, treats, or schedules patients. Its core functions are to translate HIPAA transactions into each payer's required format, validate and scrub claims for errors, route them to the correct payer, and return acknowledgements or rejections back to the billing team. Clearinghouses exist because providers need a single connection point to reach hundreds of payers, each with its own format quirks. Without one, every practice would have to maintain a direct connection to every payer's. Technically and operationally impractical. The mechanism works like this. The billing system generates an 837 file. The clearinghouse runs edits and payer-specific scrubs, then either forwards accepted claims to the payer or returns rejected claims with reason codes. Acknowledgements and electronic remittance advice flow back through the clearinghouse to the practice. It helps to distinguish the clearinghouse from similar-sounding systems. The practice management system generates the claim. The EHR captures the clinical encounter. The payer adjudication engine pays or denies the claim, and the clearinghouse is the connective tissue in between, translating, scrubbing, and routing. Question 10. A practice contracts with a payer that pays a fixed amount per member per month regardless of services used. The CMAA recognizes the payment model. Which model best fits this arrangement, distinct from fee-for-service and from bundled payments? Your options are A. Fee-for-service per visit, B. Bundled payment per episode, C. Sliding fee scale charity, D. Capitation per member per month. Take a second. Which answer would you pick? The correct answer is D. Capitation per member per month. D is correct because capitation pays providers a fixed per member per month amount regardless of services used, common in HMOs, with the practice carrying the risk of higher utilization within the contracted population for the given month. A is wrong because fee-for-service pays for each service rendered rather than a fixed per member amount, which is the opposite of the capitation model the practice is contracting under in this scenario today. B is wrong because bundled payment pays a single amount for an episode of care covering pre-op, surgery, and post-op, which differs from the per member per month structure of capitation described here. C is wrong because sliding fee scale is a financial assistance model based on patient income rather than a payer payment arrangement. So it does not match the capitation model the practice is contracting under here. Capitation is a payment model where a payer pays a provider a fixed dollar amount per member per month, regardless of how many services that member actually uses. This creates a fundamentally different incentive structure than traditional fee-for-service billing. Fee-for-service rewards volume, more visits, more revenue. Capitation flips that incentive entirely. The provider earns the same per member amount whether a patient comes in once or 12 times, encouraging preventive care and smart utilization instead. Each month, the payer sends a capitation payment based on the attributed member roster. The provider delivers covered services without billing per visit. Some services may be carved out and still billed fee for service, and quality bonuses can layer on top of the base rate. Exam questions contrast 4 models. Capitation uses a per member per month structure regardless of services used. Fee for service pays per individual service. Bundled payment covers an entire care episode, and sliding fee scale is a patient financial assistance model, not a payer arrangement at all. When you see fixed amount per member per month, attributed population, or provider accepts utilization risk, that's capitation. Shared savings and global budgets are related but distinct. Capitation is specifically the per member per month flavor. Question 11. A CMAA realizes a complaint exceeds her authority because it involves a clinical concern, an apparent HIPAA near miss, and a possible billing error. The supervisor reminds her to use a structured chain of command. Which action best aligns with the principle in this scenario? Your options are A. Try to resolve everything alone. B. Confront the involved provider directly. C. Engage manager and root concerns. D. Post the issue on social media. Before I reveal it, which one do you think is right? The correct answer is C. Engage manager and root concerns. C is correct because engaging the manager and routing concerns to the right escalation point, such as compliance for HIPAA and billing for charge questions. Let each issue reach the person with the authority and information to resolve it. A is wrong because trying to resolve everything alone exceeds the CMAA's scope and risks errors, especially for clinical and HIPAA matters that rely on roles with deeper training and formal authority within the organization. B is wrong because confronting the involved provider directly without structure can damage relationships, miss compliance steps, and shortcut the documentation that protects everyone, including the patient who raised the original concern. D is wrong because posting the issue on social media is unprofessional, can disclose protected information, and undermines the practice's ability to address the issue through internal channels designed to handle such matters. When issues arise in a medical office, they don't all go to the same person. Chain of command is the principle that every concern has a specific authority best equipped to resolve it, and routing it correctly protects everyone involved. In practice, a CMAA routes each type of concern to a different track. Clinical concerns go to a clinician, HIPAA concerns go to the compliance officer, billing questions go to the billing supervisor, and personnel issues go to the office manager. One complex complaint can easily touch several tracks at once. The structure exists because no single role has the training, authority, or tools to handle every issue. The compliance officer holds formal authority to investigate privacy matters and must log reportable incidents. The billing supervisor has access to claim data. Routing correctly applies the right tools to the right part of the problem. Exam writers test 3 classic failure modes. Investigating a HIPAA concern alone can taint the investigation and expose the practice to greater risk. Confronting a provider directly skips the documentation that protects everyone. Posting anything publicly is both a professional and a HIPAA violation. The correct answer is always to document and escalate through the right channel. Whenever a STEM includes phrases like exceeds my authority, escalate, or multiple issues, chain of command is being tested. The CMAA's role is to document the concern accurately and hand each component to the authority best equipped to resolve it. Question 12. A patient asks why insurers cannot deny her coverage for a pre-existing kidney condition or impose a lifetime cap on essential benefits anymore. The CMAA explains the source of these rights. Which law most directly establishes these specific patient protections in the scenario being described? Your options are A. OSHA Hazard Communication, B. Affordable Care Act, C. False Claims Act, D. Anti-Kickback Statute. What's your answer? Commit to one before I continue. The correct answer is B. Affordable Care Act. B is correct because the Affordable Care Act prohibits coverage, denial for pre-existing conditions, ends lifetime and annual limits on essential benefits, requires plain language summaries, and extends multiple consumer protections to insured patients across markets. G is wrong because the OSHA Hazard Communication Standard governs labels, safety data sheets, and chemical training in workplaces, which is unrelated to the insurance protections the patient is asking the CMAA to describe. C is wrong because the False Claims Act prohibits knowingly submitting false claims to the government, which addresses billing fraud rather than the patient insurance protections that the ACA puts in place under federal rules. D is wrong because the anti-kickback statute prohibits payments for referrals of federal program services and concerns provider-payer relationships rather than the consumer protections the patient is asking the CMAA to describe. The Affordable Care Act is the federal law that created uniform consumer protections across most insurance markets. Understanding exactly which protections the ACA owns and how they differ from other federal laws is the core skill being tested here. The ACA introduced 4 major patient-facing protections. Insurers cannot deny enrollment or charge more based on pre-existing conditions like asthma, diabetes, or cancer history. Lifetime and annual caps on essential benefits are prohibited. Plans must provide a standardized summary of benefits, and dependents can stay on a parent's plan until age 26. The protection works like a shield between the patient's medical history and the insurer's enrollment decision. The insurer must accept the patient, cover the condition, and cannot cap how much it will pay out over a lifetime of treatment. Exam questions often test whether you can distinguish the ACA from adjacent federal laws. OSHA covers workplace safety. The False Claims Act targets billing fraud. The anti-kickback statute and Stark law govern referral relationships. None of those address pre-existing conditions. Lifetime caps or essential benefits. That is exclusively the ACA. Whenever a question stem mentions pre-existing conditions, lifetime or annual limits, plain language summaries, or the health insurance marketplace, the answer is pointing at the ACA. Privacy questions point to HIPAA, benefit plan structure to ERISA, and workplace safety to OSHA. Each law owns its own domain. Question 13. A patient asks how Medicare and Medicaid differ in funding and eligibility. The CMAA explains the contrast in plain language. Which combination best fits the underlying contrast at this level of detail for a brief patient-facing education conversation in this kind of scenario today? Your options are A. Medicare federal age, Medicaid joint income. B. Both are state-only programs. C. Both are private insurance plans. D. Medicare income-based, Medicaid age-based. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Medicare federal age, Medicaid joint income. A is correct because Medicare is a federal program based on age or disability, while Medicaid is a joint federal-state program based on income, with different funding sources, administration, and benefit design across the two programs. B is wrong because neither program is state-only. Medicare is federal and uniformly administered by CMS, while Medicaid is a joint federal-state program with state administration under federal oversight rather than state-only operation. C is wrong because Medicare and Medicaid are not private insurance plans. They are government programs, with private plans serving different populations and following different rules from these government programs entirely. D is wrong because the contrast is reversed. Medicare is age or disability-based rather than income-based, while Medicaid is income-based rather than age-based, which is the opposite of this options framing here. Medicare and Medicaid are two distinct government health insurance programs that are frequently confused. Understanding how they differ in funding, administration, and eligibility is essential for any healthcare professional working with patients. Medicare is a federal program administered by CMS, based on age 65 and over or certain disabilities, with uniform benefits nationwide. Medicaid is a joint federal-state program, income-based, administered by individual states, and varies significantly by state in thresholds and covered services. Medicare is divided into 4 parts. Part A for hospital, Part B for outpatient, Part C as a managed care alternative, and Part D for prescription drugs. Medicaid benefits vary by state, though core services are federally mandated. Patients who are dual eligible use Medicare as primary and Medicaid as secondary. 3 related concepts are worth knowing. CHIP covers children in low-income families above Medicaid thresholds. Medicare Advantage is the Part C managed care option within Medicare, and dual eligibility describes patients who qualify for both programs at the same time. When in doubt, return to the core contrast. Medicare is age or disability-based and federally administered. Medicaid is income-based and jointly administered. Keeping these 2 anchors clear will help you guide patients and answer exam questions with confidence. Question 14. A new patient asks why she must sign acknowledgement of a notice describing how the practice may use and disclose her information. The CMAA explains the underlying HIPAA requirement that the practice provides this notice at the first encounter. Which document does this requirement describe most directly here? Your options are A. Advance Beneficiary Notice, B. Assignment of Benefits, C. Notice of Privacy Practices, D. Authorization for Treatment. Which would you go with? Lock it in before the reveal. The correct answer is C. Notice of Privacy Practices. C is correct because HIPAA requires every covered entity to provide a notice of privacy practices at first encounter, post it visibly, and obtain acknowledgement of receipt, describing uses, disclosures, patient rights, and complaint paths for the patient. A is wrong because the Advance Beneficiary Notice informs Medicare patients that a service may not be covered, which is a different document tied to medical necessity decisions and Medicare billing rather than HIPAA's privacy notice. B is wrong because the assignment of benefits authorizes the insurer to pay the practice directly rather than the patient, which is a billing form rather than the HIPAA privacy notice the patient mentions. D is wrong because the authorization for treatment supports the general clinical care plan but is not the HIPAA privacy notice. The privacy notice describes uses and disclosures of protected information rather than treatment consent. The Notice of Privacy Practices, or NPP, is the foundational HIPAA document that every covered entity must give patients. It explains how protected health information may be used, what rights patients hold, and how to file a complaint, all in one standardized notice. Every NPP must address 3 areas: how the practice uses and discloses health information, the rights patients have over that information, and the path to file a complaint, either with the practice or with the Federal Office for Civil Rights. Covered entities must fulfill 3 distribution duties: provide a copy at the very first encounter, obtain a signed acknowledgement of receipt, or document a good faith effort and post the NPP visibly in the office and on the patient-facing website. Exam questions often mix the NPP with other registration forms. The Advance Beneficiary Notice covers Medicare non-coverage of a service. The Assignment of Benefits directs the insurer to pay the practice. The authorization for treatment is general clinical consent. Only the NPP is the HIPAA-required privacy notice. One final point: the patient's signature on the acknowledgement form simply confirms they received the NPP. It does not consent to use their information. That distinction is exactly what exam writers test. Question 15. A teen patient asks the CMAA whether a parent will see her confidential mental health visit details on the family proxy portal account. The CMAA reviews the rules that limit parental access in some states for confidential adolescent services. Which underlying principle best fits this conversation today? Your options are A. All proxy access is unlimited. B. Parents must see all teen records. C. Teens never have any privacy rights. D. Adolescent privacy may limit proxy access. Don't overthink it. Which one feels right? The correct answer is D. Adolescent privacy may limit proxy access. D is correct because adolescent privacy laws limit parental access in some states for confidential services such as mental health, sexual health, and substance use, with portals configured to honor those protections through controlled proxy access. A is wrong because unlimited proxy access conflicts with adolescent privacy protections that exist precisely to support confidential care for sensitive services, and many portals are configured specifically to limit such access during adolescence. B is wrong because requiring parents to see all teen records overrides adolescent privacy protections that some states extend for confidential services, which is the opposite of how portal proxy access is typically configured. C is wrong because teens do have privacy rights for certain services in many states. So claiming they never have privacy rights misstates the framework that governs confidential services and proxy access on the portal. When a parent has proxy access to a patient portal, that access is not automatically unlimited. Adolescent privacy protections carve out exceptions for certain sensitive services, and understanding why those protections exist is essential for any medical administrative role. State laws vary, but most allow minors to consent to and keep confidential at least 3 categories of care: mental health treatment, sexual and reproductive health, and substance use treatment. These carve-outs exist because research consistently links access to confidential care in these areas with better health outcomes. At Compliant Practices, the portal is configured so that confidential service notes, lab results, and related billing items are hidden from the parent's proxy view. The teen may have a separate account with full access to their own records. This configuration is the operational expression of state law, not a technical glitch or override. 3 layers work together to protect adolescent privacy. State law defines which services a minor can consent to confidentially. Portal configuration hides those records from parental proxy accounts. And staff training ensures confidential details are never shared by phone or in person without the teen's authorization. The key exam takeaway is that parental proxy access is not unlimited when confidential adolescent services are involved. State law and portal settings may protect those records, and the CMAA's role is to know the practice policy and escalate unclear questions to the privacy officer. Question 16. A self-pay patient asks for an estimate of the cost of an upcoming procedure before scheduling. The CAVAR recognizes a federal requirement that protects this kind of caller from surprise billing. Which underlying requirement best fits the estimate the practice provides under federal law in this scenario? Your options are A. No Surprises Act good faith estimate. B. OSHA bloodborne hazard notice. C. Stark referral disclosure form. D. ICD-10 narrative description sheet. Got a guess? Lock it in. The correct answer is A. No Surprises Act good faith estimate. A is correct because the No Surprises Act requires a good faith estimate of expected charges for self-pay or uninsured patients before scheduled services, which supports informed financial decisions and a path to dispute resolution if charges exceed the estimate. B is wrong because the OSHA bloodborne hazard notice covers workplace exposure controls rather than patient cost estimates. So it does not match the federal protection that drives the estimate the patient is requesting today. C is wrong because the Stark Law concerns physician self-referral relationships rather than patient cost estimates. So it does not match the protection that drives the good faith estimate process for self-pay patients. D is wrong because an RCD-10 narrative description sheet is a coding reference rather than a federal patient protection notice. So it does not match the requirement that drives the cost estimate the patient is requesting. The No Surprises Act is a federal law that took effect in 2022, designed to shield patients from unexpected medical bills. Let's look at the specific protection it creates for self-pay and uninsured patients. When a self-pay or uninsured patient schedules care, the practice must issue a good faith estimate that includes three things: the expected items and services, the applicable diagnostic and procedure codes, and the estimated charges, all delivered before the service is performed. The workflow begins when a self-pay patient schedules a service. The billing team generates the estimate and delivers it to the patient before the appointment. If the final bill exceeds the estimate by $400 or more, the patient can trigger a federal dispute resolution process through an independent third party. It's easy to confuse the good faith estimate with adjacent documents. The Advance Beneficiary Notice protects Medicare patients from non-coverage surprises. Hospital price transparency rules require published standard charges. Stark Law and OSHA notices address referrals and workplace safety. None of these is the cost estimate protection for a self-pay caller. When an exam stem mentions a self-pay or uninsured patient, a scheduled service, and a written cost estimate, it is pointing directly at the No Surprises Act good faith estimate provision, TSOSFAS, the specific federal protection built for that scenario. Question 17. A patient asks why the CMAA confirms her insurance card information at multiple points before a visit, even though she just scheduled last week. The CMAA reviews the underlying logic for periodic re-verification of coverage. Which principle best fits the rationale for the periodic recheck in the scheduling workflow? Your options are: A. Patients always remember every detail. B. Insurance never changes mid-year. C. Coverage details can change unexpectedly. D. Card photos are always perfect. Which one is it? Pause the video if you need more time. The correct answer is C. Coverage details can change unexpectedly. C is correct because coverage details can change unexpectedly because of new employer plans, dependent status changes, or open enrollment shifts. So verification at scheduling, before, and at arrival catches updates the patient may not remember. A is wrong because patients do not always remember every detail of their plan. So relying solely on the patient's recall risks denials when coverage has changed since the most recent visit at the practice. B is wrong because insurance can change mid-year through job changes, marriage, divorce, and benefit updates. So the rechecks are designed precisely because coverage is not stable across an entire calendar year for many patients. D is wrong because card photos can become outdated when the patient's plan changes or a new card is issued. So verification rather than reliance on a photo confirms that coverage remains active and accurate. Insurance verification confirms a patient's coverage is active and accurate before services are rendered. Rather than check in once, best practice requires verification at multiple points in the workflow. Because coverage can change at any time between scheduling and the actual visit. Coverage is confirmed 3 times: at scheduling, the night before or morning of the appointment, and again at arrival. Each check catches changes the previous one could not, because plan details can shift between any 2 points in that window. Coverage changes happen for many reasons patients may not think to report. A job change, open enrollment shifts, aging off a parent's plan at 26, premium non-payment, or a life event like marriage or divorce. A patient who scheduled 6 weeks ago may be on an entirely different plan by the day of service. The mechanism behind verification is the electronic eligibility transaction. The 200 CMAA inquiry sent to the payer through the clearinghouse, and the 271 response returned with active plan details, effective dates, copay amounts, and deductible status. Many practices automate this check the night before every scheduled visit. At the desk, the CMAA confirms the card matches active eligibility and asks about any insurance changes since the last visit. Remember, periodic re-verification exists precisely because coverage changes are common. Patients may forget to report them, and a missed change leads to denied claims and unexpected patient bills. Question 18. A clinic stores substance use disorder records that received federal funding. The compliance officer notes that redisclosure rules are tighter than HIPAA, which federal regulation best fits the heightened protection that applies to those records, distinct from HIPAA's general privacy rule for sensitive content. Your options are A. Stark Physician Self-Referral Law, B. 42 CFR Part 2, C. False Claims Act, D. FDA MedWatch Program. Take a second. Which answer would you pick? The correct answer is B. 42 CFR Part 2. B is correct because 42 CFR Part 2 protects substance use disorder records more strictly than HIPAA, requiring specific consent for redisclosure when programs receive federal funding for the relevant substance use treatment activities. A is wrong because the Stark Law prohibits physician self-referral to entities with which the physician has a financial relationship, which has nothing to do with the heightened confidentiality of substance use disorder records. C is wrong because the False Claims Act addresses billing fraud and whistleblower protections rather than the heightened confidentiality of substance use disorder records, which is governed by a different federal regulation entirely. D is wrong because FDA MedWatch is the program for reporting adverse drug events and device problems to the FDA, which is unrelated to the substance use disorder confidentiality framework that applies in this scenario. Beyond HIPAA, a separate federal regulation called 42 CFR Part 2 creates heightened confidentiality protection specifically for substance use disorder treatment records. Understanding why this rule exists and how it works is essential for any healthcare compliance exam. Congress created the underlying statute because fear of disclosure was actively preventing people from seeking substance use treatment. Patients worried their records could surface in employment decisions, custody battles, or even criminal proceedings. The law removes that deterrent by guaranteeing much stronger confidentiality than HIPAA alone provides. Each disclosure under Part 2 requires a written consent form naming the specific recipient, the specific information to be shared, the purpose, and an expiration date. Critically, any record that leaves the program must carry a redisclosure prohibition notice, meaning the recipient cannot pass it along without obtaining fresh patient consent. Part 2 is frequently confused with related frameworks. HIPAA is the general privacy baseline that Part 2 supplements with stricter rules. HIPAA also provides heightened protection for psychotherapy notes, but that is a separate category. State mental health confidentiality laws may add yet another layer. Part 2 applies specifically to federally assisted substance use disorder treatment records. On the exam, signal phrases like substance use disorder records, federally assisted program, redisclosure restrictions, or stricter than HIPAA all point to 42 CFR Part 2, Glama Keti Danaksa Ornituig 1, not the Stark Law, not the False Claims Act, and not FDA MedWatch. Question 19. A patient sues directly under HIPAA, claiming financial and emotional damages from a privacy breach. The compliance officer explains a foundational rule about private causes of action under HIPAA. Which underlying point best fits accepted understanding of HIPAA enforcement options for individual patients in this case? Your options are: A. HIPAA grants a private right of action. B. Patients always recover full damages. C. HIPAA bars all state law claims. D. HIPAA grants no private action. Before I reveal it, which one do you think is right? The correct answer is D. HIPAA grants no private action. D is correct because HIPAA itself does not create a private right of action for individuals. Complaints go to the entity and to OCR, while state laws and common law theories may sometimes provide separate avenues for individual recovery. A is wrong because HIPAA does not grant a private right of action. The rule channels enforcement through OCR and through state attorneys general under HITECH rather than through individual lawsuits brought directly under the Act. B is wrong because individual patients do not always recover full damages, since HIPAA has no private right of action and state law claims depend on cause of action and proof of harm. C is wrong because HIPAA does not bar state law claims. In fact, state laws often provide separate avenues for harmed individuals to pursue remedies for privacy breaches that may parallel HIPAA's federal enforcement model. HIPAA is a federal privacy law, but it contains a critical limitation that surprises many people. It does not include a private right of action. That means an individual who believes their health information was improperly disclosed cannot sue the covered entity directly under HIPAA itself. Instead of going to court, enforcement runs through the federal government. A patient files a complaint with the Office for Civil Rights, which investigates the covered entity, requests records, and can impose penalties ranging from corrective action plans to substantial fines. State law can sometimes provide a separate avenue. Tort theories like breach of confidentiality, negligence, and invasion of privacy may allow a patient to sue under state law. Courts may also treat HIPAA as evidence of the standard of care in a state negligence claim, even though HIPAA is not the direct basis for the lawsuit. Exam questions on this topic use predictable traps. Claims that HIPAA grants a private right, that patients always recover damages, or that HIPAA blocks all state claims are all incorrect. The correct principle is that individual suits under HIPAA are not available and complaints go to OCR. When you see a question about a patient wanting to sue under HIPAA, remember, HIPAA routes enforcement through the government, not the courts. State law and OCR complaints are the real avenues, not a personal lawsuit under HIPAA itself. Question 20. A new policy revises which abbreviations are acceptable in transcription. The CMAA reads that micrograms should now be abbreviated MCG rather than the Greek letter mu, followed by G. Which underlying safety concern most directly drives this transcription change in clinical documentation? Your options are: A. Risk of milligram misread. B. Pharmacy software incompatibility. C. Cost of typing special characters. D. Patient confidentiality concerns. What's your answer? Commit to one before I continue. The correct answer is A. Risk of milligram misread. A is correct because mu followed by G for micrograms can be misread as milligrams, producing 1,000-fold overdose. So writing MCG removes the visual ambiguity and is the recommendation on the ISMP error-prone abbreviations list for safety. B is wrong because while some software cannot render the Greek letter mu cleanly, the policy change is driven by patient safety and dose misreading risk, rather than pure software display problems in the pharmacy system. C is wrong because the cost of typing special characters is not a meaningful clinical justification, and policy changes around dose abbreviations are based on documented safety incidents rather than on typing convenience. D is wrong because patient confidentiality concerns relate to access controls and disclosure practices, not to the visual misreading of dose abbreviations, which is what drives the mu2 MCG recommendation in clinical practice. Error-prone abbreviations are those that have caused documented patient harm because they are easily misread. Two major safety organizations, ISMP and the Joint Commission, maintain official lists of abbreviations to avoid and their recommended replacements. The Greek letter mu closely resembles the letter M in handwriting, faxes, and degraded print. This means a dose written as mg for micrograms can easily be misread as mg for milligrams. A 1,000-fold difference that can be lethal. The abbreviation MCG uses three plain Roman letters that cannot be visually confused with mg in any context, or so intig, handwriting, fax, or electronic display. Every reader, from prescriber to pharmacist to nurse, sees and interprets it identically. The sole driving concern behind these recommendations is patient safety through dose misreading prevention. Distractors like software incompatibility, typing cost, or confidentiality miss the point entirely. The rationale is documented harm and the need to eliminate visual ambiguity at the source. Question 21. A clinic closes at the end of the day with a checklist that confirms no patients remain, reconciles cash, secures records, sets thermostats, and activates the alarm. The CMAA recognizes the underlying purpose of this closing routine. Which underlying purpose best fits the closing checklist at the practice today? Your options are: open the office for night appointments. B. Replace the front desk staff overnight. C. Secure site and complete daily reconciliation. D. Run a marketing event in the lobby. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Secure site and complete daily reconciliation. C is correct because closing procedures secure the site and complete daily reconciliation, including confirming no patients remain, reconciling cash, securing records, checking refrigerator locks, setting thermostats, locking, and activating the alarm before the staff leaves. A is wrong because opening the office for night appointments contradicts a closing checklist, which prepares the site for the end of the workday rather than for additional appointments during the night at the practice. B is wrong because replacing front desk staff overnight is unrelated to closing procedures, which focus on site security and reconciliation rather than personnel changes at the practice during the closing routine itself. D is wrong because a marketing event in the lobby is unrelated to closing procedures, which focus on site security and reconciliation rather than promotional events at the practice during the end of the workday. At the end of every clinical day, medical officers follow a structured closing routine. This isn't just locking up. It's a verifiable sequence designed to protect finances, patient data, medications, and the building itself. Closing procedures exist because the office holds significant value at day's end across 4 domains: cash and posted payment data, patient records on screens and in print, medications and specimens requiring correct refrigerator temperatures, and the physical security of the building itself. Closing tasks are divided by role. The front desk CMAA handles reconciliation and securing patient information. The clinical lead confirms the building is clear and checks refrigerator logs. The last person out sets the thermostat, locks up, and activates the alarm. Assigned closing log documents that each step was completed. 3 concepts are commonly confused with closing procedures. Opening procedures are the morning counterpart. Nightly batch processing is a billing system activity focused on data. After hours coverage is an on-call clinical arrangement. Closing procedures are specifically the operational checklist that bridges the active workday and the locked alarm building overnight. When you see signal phrases like reconcile cache, refrigerator log, secure records, or activate alarm, those point directly to closing procedures. The core purpose is always securing the site and completing daily reconciliation, not staffing, marketing, or reopening tasks. Question 22. A pediatrics group books all well baby checks on Tuesday mornings to streamline staffing, room setup, and equipment. The CMAA recognizes the scheduling tactic at work. Which scheduling type best fits this arrangement of similar visit types together on the same morning of the week? Your options are A. Wave at top of every hour, B. Stream at fixed intervals, C. Open access reserved for all, D. Cluster scheduling for similar visits. Which would you go with? Lock it in before the reveal. The correct answer is D. Cluster scheduling for similar visits. D is correct because cluster scheduling groups similar visit types together to improve efficiency for staff and equipment, often used for well baby checks, suture removals, or other visit categories with shared workflow needs. A is wrong because wave scheduling assigns several patients to the same start time, which is a different efficiency tactic that absorbs no-shows but does not specifically group similar visit types together. B is wrong because stream scheduling assigns each patient a unique fixed interval time and does not group similar visit types together by morning or by category in the manner described in this scenario. C is wrong because open access scheduling holds capacity for same-day demand rather than grouping similar visit types together by category, so it does not match the cluster pattern described in this scenario. Cluster scheduling is a template-based tactic that groups similar visit types into the same morning, afternoon, or day. Understanding why it exists and how it differs from other scheduling models is the key to recognizing it on the exam. The core problem cluster scheduling solves is friction from variety. When a morning mixes well baby checks, sick visits, and chronic disease follow-ups, the team repeatedly swaps mental models, reconfigures rooms, and pulls different equipment. Clustering eliminates that by making each period a mini-assembly line of identical tasks. The mechanism lives in the scheduling template itself. Protected slots are labeled for a specific cluster type, and front desk staff can only book matching visits into those slots. Clinical staff prepare rooms and supplies for the day's cluster in advance, something impossible with a mixed schedule. Exam writers test your ability to contrast cluster scheduling with 4 other models. Wave assigns multiple patients to the top of each hour. Stream gives every patient a unique fixed interval slot. Open access reserves capacity for same-day demand. Only cluster scheduling groups similar visit types together. That specific feature is the signal. When an exam stem mentions phrases like all well baby checks on Tuesday mornings, protected slots for a category, or streamlined staffing and equipment, it is pointing directly at cluster scheduling. Same start time at the top of the hour signals wave. Same day capacity signals open access. Question 23. A patient asks the CMAA to send only minimum information to a specific consultant rather than the entire chart. The CMA recognizes a HIPAA principle about how much information should be shared in routine disclosures during care. Which underlying principle best fits the limit being described to this caller? Your options are A. Maximum disclosure preferred, B. Minimum necessary standard, C. Open access to everyone, D. Audit log requirement. Don't overthink it. Which one feels right? The correct answer is B. Minimum necessary standard. B is correct because the minimum necessary standard limits use, disclosure, and request of protected information to the smallest amount needed for the purpose, with exceptions for disclosures to the patient and to providers for treatment under federal rules. A is wrong because maximum disclosure is not the rule. The privacy rule was built around a minimum necessary standard precisely to prevent unnecessary sharing of protected information beyond what the purpose actually requires. C is wrong because open access to everyone runs counter to the privacy rules protections and to role-based access controls that limit who can see what within the chart for compliant operations. D is wrong because the audit log requirement applies to recording every access in the system rather than the volume of information shared in a particular disclosure to an outside consultant for the patient. The minimum necessary standard is a HIPAA principle that limits protected health information to the smallest amount needed for the intended purpose. It applies broadly across uses, disclosures, and requests, but with important exceptions. The standard has 4 recognized exceptions: disclosures to the patient themselves, treatment communications between providers, legally mandated disclosures, and releases covered by a patient-signed authorization that defines its own scope. In practice, when a specialist requests records for a consult, the CMAA sends only the imaging results and the relevant referral note, not the entire chart. Unrelated records, like older mental health visits, stay behind because they serve no purpose in this disclosure. Organizations enforce minimum necessary through 6 operational layers: role-based EHR access, release of information procedures, targeted form design, staff training, periodic audits, and confirming scope with the requesting party before transmitting. Minimum necessary is a volume principle, not maximum disclosure, not open access, and not the audit log. The right answer always limits information shared to exactly what the purpose requires, with the defined exceptions in mind. Question 24. A scheduler creates a new chart for a patient named Maria Garcia, but later finds an existing chart for Maria E. Garcia with the same date of birth. The CMAA recognizes a duplicate record concern that policy says to handle a specific way. Which response best fits accepted policy? Your options are: A. Stop, notify him, do not merge alone. B. Merge the 2 records immediately. C. Delete one of the duplicate records. D. Ignore and proceed with separate charts. Got a guess? Lock it in. The correct answer is A. Stop, notify him, do not merge alone. A is correct because when a duplicate is suspected, the CMAA stops creating new chart entries, notifies the Health Information Management Team, documents the discrepancy, and does not merge unilaterally, since merging requires HIM-level access and review. B is wrong because merging the 2 records unilaterally bypasses the formal HIPAA process and audit trail, which exists to confirm identity and preserve the clinical content during the merge action by qualified staff. C is wrong because deleting one of the duplicate records can lose clinical information and is not the appropriate action. HIM combines records carefully so that all clinical content is preserved through the merge process. D is wrong because ignoring the duplicate and proceeding with separate charts fragments the patient's history, undermines safety, and creates downstream billing and clinical issues that the duplicate process is designed to prevent. When a patient already has a chart in the system, but a second one gets created under a slightly different name or date of birth, the 2 charts split that patient's clinical history and create serious safety and billing problems. Duplicates usually arise from small data entry differences at registration, a nickname instead of a legal name, a dropped middle initial, or a transposed digit in the date of birth, each one enough to fool the system into building a brand new chart, The correct front desk response follows 3 steps. Stop creating any new chart entries. Document the suspected duplicate with both chart numbers and the reason for suspicion. And notify Health Information Management through the established channel. Health Information Management holds the access. Training and formal process to verify identity. Safely combine the records. Preserve all clinical content. And maintain a complete audit trail. Protections that are bypassed if front desk staff attempt the merge on their own. Remember, the front desk detects and reports, HIM decides and merges. Any shortcut that skips notification risks fragmenting care further and compromising the integrity of the medical record. Question 25. A new staff member asks why CMAAs are advised against typing on a keyboard, while a patient describes a sensitive personal concern in front of the desk. The supervisor explains a nonverbal principle relevant to attentive listening. Which principle best captures the supervisor's underlying explanation in this case? Your options are A. Speed of typing reduces accuracy. B. Privacy laws prohibit typing entirely. C. Divided attention undermines presence. D. Patients prefer paper forms always. Which one is it? Pause the video if you need more time. The correct answer is C. Divided attention undermines presence. C is correct because divided attention undermines presence. Since typing during a sensitive disclosure communicates that the patient's words are secondary to the screen, which weakens trust and reduces the depth of the exchange. A is wrong because typing speed and accuracy are not the issue at hand. The supervisor is teaching a relational and nonverbal point about attentiveness rather than a technical concern about how quickly forms are filled out. B is wrong because privacy laws permit appropriate typing of patient information at the registration workstation. The supervisor's coaching is about presence and attention rather than a regulatory restriction on keyboard use during disclosure. D is wrong because patient preference for paper or electronic forms is a separate operational question. The immediate concern is that typing during sensitive disclosure conveys distraction, even when paper might also be available. Active listening is a communication discipline that goes far beyond simply hearing words. At the front desk, it means giving a patient your full, undivided attention, especially when what they are sharing is sensitive or personal. Active listening involves 4 key behaviors: setting aside the keyboard and turning towards the patient, maintaining eye contact, asking clarifying questions and reflecting back what was heard, and pausing before responding so the patient can fully finish their thought. When a CMAA types during a sensitive disclosure, the nonverbal message is that the screen matters more than the patient. Trust drops, and the depth of what the patient is willing to share drops with it. Stopping the typing and turning toward the speaker signals presence and keeps those critical signals from being missed. Exam distractors often point to typing speed, privacy law prohibitions, or patient preferences for paper forms. None of these capture the relational principle being tested. Active listening at the front desk is specifically about undivided attention and trust, not regulatory or technical concerns. The takeaway is straightforward. Divided attention undermines presence, and presence is what makes patients feel safe enough to share. No extra time is required, just a pause, a turn, and full attention before the typing resumes. Question 26. A scheduler creates a chart for Robert Smith but later finds an existing chart for Bob Smith with the same date of birth. The CMAA recognizes a possible duplicate record. Which combination of practices most directly helps prevent this kind of duplicate creation at registration? Your options are A. Trust the patient's stated spelling. B. Skip phonetic search to save time. C. Use only last name in search. D. Use two identifiers and search nicknames. Take a second. Which answer would you pick? The correct answer is D. Use two identifiers and search nicknames. D is correct because using at least two identifiers, such as full name and date of birth, and searching common nicknames and spelling variants reduces duplicate record creation for patients whose names appear in multiple forms in the system. A is wrong because trusting only the patient's stated spelling can miss prior records under maiden, hyphenated, or nickname versions of the name, increasing the risk of building a parallel chart that fragments the patient's history. B is wrong because skipping phonetic search saves a few seconds at registration but increases duplicate creation, which then requires costly merging by health information management staff later in the patient's care relationship. C is wrong because using only the last name leaves out date of birth, common name resolution, and nickname checks, all of which are needed to confirm that the patient does not already have an existing record. Patient registration relies on a two identifier rule to ensure the right chart is opened for the right patient. This principle exists because single identifier matching a MUT, like last name alone, produces too many false positives in real clinical practice. Common names like Robert Smith can belong to multiple patients in the same practice. A single identifier produces a one-in-many problem, which has led to documented harms including wrong patient procedures and incorrect prescriptions. Combining full name with date of birth dramatically narrows the match. The registration sequence has three key steps. First, the patient states their full name and date of birth. Second, the staff searches the master patient index including phonetic matches, nicknames, and spelling variants. Third, any potential match is confirmed using a secondary identifier like address or phone number before selecting or creating a record. When a patient registers as Bob Smith and no exact match appears, the CMAA expands the search to Robert and Bobby Smith. If a Robert Smith with the same date of birth appears, the CMA confirms the address, links the patient to the existing chart, and a duplicate is prevented at the source. The two identifier rule combined with nickname and phonetic searching is the frontline defense against duplicate records. Trusting patient spelling alone or using only a last name are the exam traps. Always pair full name and date of birth. Then search variants before creating any new chart. Question 27. A practice introduces a new pre-visit intake form on the patient portal. After 2 weeks, the front desk notices that providers complain about incomplete intake at rooming. Which response best reflects effective collaboration between front office and clinical staff in this situation? Your options are: A. Review the form with clinical input. B. Stop using the new form entirely. C. Blame the providers in writing. D. Ignore the feedback and proceed. Before I reveal it, which one do you think is right? The correct answer is A. Review the form with clinical input. A is correct because reviewing the intake form together with clinical staff identifies which fields are not completing, why, and how to adjust prompts so the form supports rooming, reflecting the interdependence of administrative and clinical processes. B is wrong because abandoning the form discards potential efficiency gains rather than fixing the root cause, and ignores the value of pre-visit data for both clinical decision-making and downstream documentation accuracy. C is wrong because blaming providers in writing creates a hostile work environment, undermines team trust, and avoids the actual problem of an intake form that may not match how rooming staff use information. D is wrong because ignoring legitimate clinical feedback allows preventable rooming delays to continue, which damages patient experience and weakens the collaborative culture that supports both front office and clinical workflows. When workflows like pre-visit intake span both front office and clinical teams, problems in one area almost always have causes and fixes that involve both. Effective practice operations depend on both teams working together rather than in silos. There are 4 common responses to intake friction, but only one works. Blaming providers and right-in damages relationships. Ignoring the complaint lets the problem persist. Stopping the form eliminates efficiency gains for everyone. Only a collaborative review actually fixes the underlying issue. The mechanism for effective collaboration is a brief, structured review. Both teams examine specific incomplete intakes together, identify the friction points, like a confusing toggle hiding a medications field, and then propose and test changes on a small batch before rolling out broadly. In practice, this looks like a 30-minute session where a front office manager, a clinical lead, providers, rooming staff, and a CMAA all examine recent incomplete intakes together. Their shared goal is to find exactly where the form or workflow is breaking and redesign it collaboratively. The core principle is simple. Blame and avoidance produce worse outcomes than shared problem solving. Signal phrases like review with clinical input, identify root cause, and test the change all point to the collaborative response, and that is always the right answer. Question 28. A claims allowed amount is less than the billed charge for an in-network claim. The CMAA records the difference as a routine reduction tied to the contract. Which underlying category best fits this routine reduction in everyday billing language? Your options are A. Bad debt write-off, B. Charity care write-off, C. Contractual adjustment, D. Hardship adjustment. What's your answer? Commit to one before I continue. The correct answer is C. Contractual adjustment. C is correct because contractual adjustments are the routine difference between billed charges and the contracted allowed amount for in-network claims, automatically applied when claims process and reflected in the aging and reconciliation reports for the practice today. A is wrong because bad debt write-offs apply when collection efforts have failed, rather than to the routine difference between billed charges and the allowed amount under an in-network contract for the visit being adjudicated. B is wrong because charity care write-offs apply when the patient cannot pay through a means-tested financial assistance application, rather than to the routine in-network billed versus allowed difference being recorded in this scenario. D is wrong because hardship adjustments are tied to specific patient circumstances and documented financial assistance, rather than to the routine in-network billed versus allowed difference being recorded for this claim today. When a practice bills a standard charge to an in-network payer, the allowed amount is almost always lower than what was billed. The difference between those two figures is called a contractual adjustment, a routine, automatic reduction built into every in-network claim. Practices maintain one standard fee schedule and bill the same charge to every payer. When the remittance advice arrives, the system automatically posts the plan payment, the patient responsibility, and the contractual adjustment, reducing the account receivable to the contracted allowed amount. The contractual adjustment is a contra revenue entry, which means it reduces gross revenue to the contracted net revenue level. It does not signal any failure. It is simply the expected accounting outcome of participating in an in-network agreement. Exam questions frequently test whether you can distinguish contractual adjustments from other reduction types. Bad debt applies when collection has failed. Charity care applies when a patient qualifies for financial assistance. Hardship adjustments are case-specific. Only contractual adjustments are routine, automatic, and contract-driven. When a STEM describes an in-network claim where the allowed amount is less than the billed amount and the reduction posts automatically on the remittance, that is always the contractual adjustment, not a write-off, not charity care, and not hardship. Question 29. A breach of protected information affects 600 individuals in a single state. The compliance officer reviews notification obligations to individuals, the federal government, and the public. Which notification combination best fits HIPAA's breach notification rule for this kind of single jurisdiction breach involving 600 people? Your options are A. Individuals only, nothing else. B. Individuals, HHS, prominent media outlet. CHS only, nothing else. D. Patients, family members, insurer. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Individuals, HHS, prominent media outlet. B is correct because breaches affecting 500 or more individuals in a single state require notice to the affected individuals, notice to HHS, and notification to a prominent media outlet under the Federal Breach Notification Rule. A is wrong because individuals must be notified, but federal notice and media notice are also required for breaches above the 500 threshold in a single jurisdiction. Individual notice alone falls short of the rule. C is wrong because HHS must be notified, but individuals and a prominent media outlet must also receive notice when the breach affects more than 500 people in a single state under the federal rule. D is wrong because notifying family members and the insurer is not the structure required by the breach notification rule, which sets specific notice obligations to the affected individuals, to HHS, and to the public. When protected health information is breached, HIPAA's breach notification rule sets out exactly who must be told and when. The obligations depend on the scale of the breach, specifically whether fewer or more than 500 individuals are affected. Breaches affecting 500 or more individuals in a single state trigger a 3-channel requirement: notification to affected individuals, notification to the Department of Health and Human Services, and notification to a prominent media outlet serving that state or jurisdiction. Each channel serves a distinct purpose. Individual notice tells each person what was exposed and what to do, such as credit monitoring. HHS notification supports federal oversight and aggregates breach data. Media notification reaches affected individuals whose contact information may no longer be current. The 500 individual threshold is the key dividing line. Smaller breaches still require individual notification and an annual HHS log entry. Larger breaches add the 60-day HHS deadline and the media notification requirement. All 3 channels together form the required response. When a breach clears 500 individuals in a single state, all 3 notifications are required as a package: individual notice, HS notice within 60 days, and prominent media notice. Knowing this 3-channel structure and the threshold is what the exam tests. Question 30. An MRI is planned for a patient. The CMAA submits clinical documentation to the payer to confirm coverage and obtains an approval number, valid dates, and units approved. Which term best fits this approval? Distinct from referral and from predetermination in this kind of imaging scenario at the practice today? Your options are A. Advance beneficiary notice. B. Notice of privacy practices. C. Code of conduct certification. D. Pre-certification or pre-authorization. Which would you go with? Lock it in before the reveal. The correct answer is D. Pre-certification or pre-authorization. D is correct because pre-certification or pre-authorization confirms that the proposed service is medically necessary and will be covered under the patient's plan, with an approval number, valid dates, units approved, and specific procedures listed for the service. A is wrong because the advance beneficiary notice informs Medicare patients about possible non-coverage of a specific service, rather than the prior approval submitted to a payer for elective imaging in this scenario. B is wrong because the Notice of Privacy Practices describes how protected information may be used and disclosed under HIPAA, rather than the prior approval submitted to a payer for the specific imaging service in this scenario. C is wrong because Code of Conduct certification is unrelated to insurance approval workflows, since the CMAA submission concerns prior approval of a planned service rather than personnel certification at the practice. Pre-certification, also called pre-authorization, is the process where a payer confirms in advance that a planned service is medically necessary and will be covered. It's a prospective binding approval obtained before the service is rendered. When a pre-certification is approved, the payer returns an authorization number, the approved procedures, valid dates during which the service can occur, and the number of approved units. The practice records all of this and references it on the claim. Pre-certification is often confused with three other terms. A referral is a primary care direction to see a specialist. Predetermination is only a coverage estimate, not binding. An advance beneficiary notice tells Medicare patients a service may not be covered. None of these is a prior approval. The practice gathers clinical documentation, diagnosis, proposed procedure, prior treatments, and supporting labs or imaging, and submits it through the payer's channel. The payer reviews it and returns an authorization number, valid dates, and approved units, which the practice records before scheduling. On exam questions, signal phrases like planned service, authorization number, valid dates, units approved, and medical necessity all point to pre-certification, the prospective binding approval that prevents denials before the service ever happens. Question 31. A clinical letter dictates a procedure called cholecystectomy. The CMAA must explain the meaning to the patient in plain language while writing a follow-up note, which decoded translation, built from the word parts, best captures what the procedure actually accomplishes for the patient. Your options are A. Surgical removal of the gallbladder, B. Visualization of the colon, C. Repair of a hernia opening, D. Stone crushing for the bladder. Don't overthink it. Which one feels right? The correct answer is A. Surgical removal of the gallbladder. A is correct because cholecystectomy combines chole for bile, cyst for sac or bladder, and ectomy for surgical removal. So the procedure removes the gallbladder, often performed for symptomatic gallstones or recurrent cholecystitis. B is wrong because visualization of the colon describes a colonoscopy, which uses different word parts and a flexible scope rather than the surgical removal indicated by the suffix ectomy in the dictated term. C is wrong because repair of a hernia opening describes a herniorrhaphy or hernioplasty, neither of which match the chole and cyst roots that point to bile, and the bladder-shaped gallbladder structure. D is wrong because stone crushing for the bladder describes lithotripsy and uses litho and tripsy word parts, so it does not align with the bile-related cholecystectomy operation described in the dictated note. Medical terms aren't random, they're casual. They're built from reusable word parts that can be separated and translated. Mastering this skill lets you decode terms you've never memorized before. Every medical term is built from three kinds of parts. Prefixes appear at the beginning and modify meaning. Roots name the body structure or system. Suffixes define the broad action or condition, and that's where decoding should start. Take cholecystectomy. The suffix ectomy tells us this is a surgical removal. The roots chole and cyst point to bile and the bladder-shaped storage organ, together naming the gallbladder. Combined translation, surgical removal of the gallbladder. The root chole recurs across many biliary terms, actois. The suffix and modifying root determine the specific meaning. Cholecystitis is gallbladder inflammation. Cholelithiasis is the condition of having gallstones. Cholangiography is imaging of the bile ducts. The exam test, decoding skill, not rote memorization. Identify the suffix first, then the root or roots, and the meaning assembles itself, even for terms you've never seen before. Question 32. A clinic letter mentions that a patient experienced bradycardia overnight while admitted for monitoring after a procedure. The CMAA must explain the term using its prefix and root meanings to a family member who asks, which decoded meaning best matches the term as used in the chart. Your options are A. Fast heart rate above 100. B. Inflammation of cardiac muscle. C. Slow heart rate below 60. D. Surgical removal of heart tissue. Got a guess? Lock it in. The correct answer is C. Slow heart rate below 60. C is correct because bradycardia combines brady meaning slow with cardio meaning heart. So the term refers to a slow heart rate, generally defined as fewer than 60 beats per minute in adults. A is wrong because a fast heart rate above 100 is tachycardia, built from tachy meaning fast plus cardio for heart. So the prefix opposite is what is being described in this scenario. B is wrong because inflammation of cardiac muscle is myocarditis, formed from myo for muscle, cardio for heart, and it is for inflammation, which is a different concept than slow heart rate. D is wrong because surgical removal of heart tissue would use the suffix ectoma combined with a heart-related root, but that surgical action is not implied by the rate-related prefix brady at all. Bradycardia is a medical term built from two word parts that together describe a slow heart rate. Understanding how the parts combine helps you decode not just this term, but an entire family of related clinical vocabulary. The prefix brady means slow, the root cardio refers to the heart, and the suffix IA denotes a condition. Together they resolve to a slow heart rate, clinically defined as fewer than 60 beats per minute in adults. The prefix is what carries the diagnostic distinction. Brady and tachy share the same cardio root but describe opposite conditions. Bradycardia is below 60 beats per minute, while tachycardia is above 100. Swapping that one prefix changes the entire clinical meaning. On a chart or monitor, bradycardia and tachycardia look like similar words, but their prefixes signal opposite physiological states. Recognizing brady versus tachy instantly tells a CMAA whether a patient's heart rate dropped below 60 or climbed above 100. Because brady is a consistent prefix across medical terminology, learning it once unlocks an entire family of terms. Bradypnea describes slow breathing, bradykinesia describes slow movement, and bradyarrhythmia describes a slow irregular rhythm, all decoded using the same prefix you already know. Question 33. An infusion clinic uses barcode scanning to verify the patient wristband and the medication label before administering each dose. The verification confirms right patient, right drug, right dose, right route, and right time. Which record in the EHR captures this administered medication detail? Your options are A. Problem list, B. Allergies list, C. Encounter progress note, D. Medication administration record. Which one is it? Pause the video if you need more time. The correct answer is D. Medication administration record. D is correct because the medication administration record, often called the EMA in inpatient and infusion settings, documents medications actually given and supports barcode scanning to verify the 5 rights at the point of care. A is wrong because the problem list captures active and resolved diagnoses with onset and status information, not the moment-to-moment record of medications a patient actually receives during a clinical encounter or infusion. B is wrong because the allergies list records drug, food, environmental, and latex allergies with reactions and severity, but it does not capture the verification or administration of each individual medication dose. C is wrong because encounter progress notes describe the visit narrative using formats such as SOAP, while the actual administration of each medication dose is documented separately in the medication administration record. The Electronic Medication Administration Record, or EMA, is the chart document that records every dose actually given to a patient. It exists because prescribing, dispensing, and administering are three separate events, and errors can happen at each one. The prescriber enters an order, the pharmacy dispenses the medication, and the clinician administers the dose at the bedside or infusion chair. The EMA is specifically designed to verify and document that third step, administration, which no other chart document captures. At the point of care, the clinician scans the patient's wristband and the medication label. The EMA checks both against active orders and either confirms a match or fires an alert. This barcode workflow enforces the 5 rights: right patient, right drug, right dose, right route, and right time. Exam questions often test whether you can distinguish the EMA from lookalike documents. The problem list tracks diagnoses, the allergies list records reactions, and progress notes describe the visit narrative. Only the EMA captures the moment-to-moment record of medications actually administered. When a question stem mentions barcode scanning, wristbands, medication labels, 5 rights, or timestamps of doses given, it is pointing to the EMA. Order entry, pharmacy dispensing, and medication reconciliation are related but distinct steps. The EMA owns administration. Question 34. A practice unbundles services and bills components separately when a single bundled code applies. The CMAA recognizes a federal compliance concern about this kind of pattern in claim submission. Which underlying concern best fits the federal compliance risk created by improper unbundling in this kind of billing scenario? Your options are A. OSHA bloodborne hazard risk, B. Fraud risk under coding rules, C. ADA accessibility violation risk, D. Joint Commission survey risk. Take a second. Which answer would you pick? The correct answer is B. Fraud risk under coding rules. B is correct because improper unbundling carries fraud risk under federal coding rules and can violate the False Claims Act, with NCCR edits identifying code pairs that should not be billed together and triggering payment adjustments at the payer level. A is wrong because the OSHA bloodborne hazard standard applies to workplace exposure to infectious materials rather than billing fraud, so it does not match the compliance risk created by unbundling in this scenario. C is wrong because ADA accessibility concerns relate to physical and communication access for individuals with disabilities rather than billing practices, so they do not match the compliance risk created by unbundling here. D is wrong because Joint Commission survey concerns focus on accreditation standards across many domains, but the specific compliance risk from unbundling falls under federal coding rules and the False Claims Act framework instead. When a single bundled procedure code covers a combination of services, billing those components as separate codes is called unbundling. Understanding why this is a federal compliance concern and how the system catches it is essential for any practice. The financial harm is direct. The bundled code represents the correct payment for the combined work, including pre-procedural prep, the procedure itself, and routine post-procedural care. Splitting those components apart and billing each one separately inflates the total reimbursement beyond what the bundled rate would have produced. The National Correct Coding Initiative, NCCA, publishes a set of code pair rules identifying which two codes should never be billed together. When a claim arrives with a flagged pair, the payer's adjudication engine automatically denies one code or adjusts payment. In certain clinical circumstances, a valid modifier can override the edit, but only when documentation supports it. Unbundling is distinct from other billing integrity concerns. Upcoding means billing a higher level code than documentation supports. Modifier abuse means using modifiers to bypass edits without supporting documentation. Balance billing involves charging patients beyond the contracted amount. Unbundling specifically means breaking apart a bundle that should remain a single code. When a practice intentionally splits bundled codes and knows, or should know, the bundled code applies, that conduct can rise to the level of a False Claims Act violation. In NCCI, edits catch many patterns automatically, but systematic bypass attempts trigger audits and recoupment. Question 35. Medicare requires submission of claims within 12 months of the date of service. The CMAA recognizes the underlying timely filing rule. Which combination best fits accepted timely filing parameters across major payers, including Medicare, Medicaid, and commercial payers, at this practice during a routine review today? Your options are A. Medicare 12 months, others vary. B. All payers exactly 30 days. C. All payers 10 years filing. D. No timely filing rules exist. Before I reveal it, which one do you think is right? The correct answer is A. Medicare 12 months, others vary. A is correct because Medicare's timely filing limit is 12 months from the date of service, while Medicaid is state-specific and commercial payers range from 90 days to a year, with late claims denied for timely filing. B is wrong because 30 days is shorter than the actual timely filing limits used by Medicare, Medicaid, and commercial payers, which range from 90 days to a year depending on the payer and contract terms. C is wrong because 10 years is far longer than any standard timely filing limit used by Medicare or commercial payers, and would not match the actual filing windows used in current healthcare billing practice. D is wrong because timely filing rules do exist for every payer. Ignoring them risks denials and unrecoverable revenue, which is exactly why the practice tracks submission dates against payer-specific filing limits. Timely filing limits are payer-imposed deadlines for submitting claims after the date of service. Missing these deadlines almost always means the revenue is permanently lost, even when the service was covered and properly provided. Medicare has a firm 12-month limit from the date of service. Medicaid limits vary by state, typically 90 days to 1 year. Commercial payers set their own contract-specific limits, also often in that same range. Claims arriving after any of these cutoffs are denied for timely filing with very limited appeal options. Managing timely filing requires coordination across three components. The billing system tracks every charge from date of service through submission. The clearinghouse provides acknowledgements proving the payer received the claim. And the billing workflow includes regular review of aged claims approaching the deadline. These limits exist because payers need to close out claim processing rather than face open-ended liability indefinitely. The deadline creates a clean accounting cutoff, encourages efficient billing practices, and gives both sides predictable cash flow, but the burden of meeting it falls entirely on the practice. Remember that timely filing is distinct from appeals timelines, corrected claim windows, and state timely payment laws. Those all apply after a claim is received. Timely filing governs only the original submission, making prompt tracking from the date of service non-negotiable. Question 36. A clinic manager is comparing two arrangements. One shares savings with Medicare against a benchmark across an attributed population. The other uses a registry, a care manager, and a consulting psychiatrist to embed behavioral health. Which statement best distinguishes them? Your options are A. Both rely on flat monthly fees. B. Both require NCQA recognition. C. Only one bills insurance carriers. D. One is contracting, one clinical. What's your answer? Commit to one before I continue. The correct answer is D. One is contracting, one clinical. D is correct because an accountable care organization is a contracting structure that shares saving against a cost benchmark across a population, while collaborative care is a clinical staffing model embedding behavioral health into primary care delivery. A is wrong because neither model is defined by flat monthly membership fees. That arrangement describes concierge or direct primary care, which is a separate option that bypasses traditional insurance-based contracting and clinical staffing. B is wrong because NCQA recognition is the hallmark of a patient-centered medical home, not a defining requirement for either accountable care contracts or the clinical staffing structure used in the collaborative care approach. C is wrong because both arrangements use insurance-based billing through normal channels, so insurance participation alone fails to separate a population-level shared savings contract from a clinical behavioral health staffing approach. These two arrangements show up together in policy discussions, but they operate at completely different layers of the healthcare system. Understanding what each one actually is, and not just what it aims to do, is the key distinction. An ACO is a contract between a provider group and a payer like Medicare. Patients are attributed to the ACO, a cost benchmark is established, and if the group meets quality measures and comes in under the benchmark, they share in the savings at annual reconciliation. Collaborative care is a clinical staffing model, not a contract. It embeds a behavioral health care manager and a consulting psychiatrist into primary care, and uses a patient registry to track outcomes for conditions like depression and anxiety between visits. Exam writers mix these arrangements deliberately. ACOs center on shared savings and attributed populations. Collaborative care centers on a registry, a care manager, and an embedded psychiatrist. Adjacent distractors include the PCMH, bundled payments, and direct primary care, each with its own distinguishing feature. The two can coexist in the same practice, but they are not the same kind of thing. One is a contracting structure with a payer. The other is a clinical workflow that brings behavioral health into primary care. Question 37. A patient cannot pay the full balance after an emergency visit and asks the CMA about options the practice offers. The CMAA reviews payment plans and a sliding scale where applicable. Which combination best fits accepted practice for this kind of patient financial conversation at the practice in this scenario? Your options are A. Demand cash today only. B. Refuse to discuss any plan. C. Document agreement, reasonable monthly amounts. D. Send to collections immediately. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Document agreement, reasonable monthly amounts. C is correct because payment plans set up agreements for amounts the patient cannot pay in full, documented in writing with reasonable monthly amounts, often interest-free where policy permits, and default procedures defined for missed payments at the practice. A is wrong because demanding cash today only conflicts with the principle of payment plans, which exists precisely because some patients cannot pay in full immediately and need a structured path to settle the balance over time. B is wrong because refusing to discuss any plan abandons the patient and the practice's responsibility to support reasonable financial arrangements, which is the opposite of the support the financial counseling role provides at the desk. D is wrong because sending to collections immediately skips the standard escalation process, which begins with statements, calls, and a payment plan offer before considering external collection through any agency at the practice. When a patient can't pay a large medical bill all at once, a payment plan offers a structured middle path. Instead of demanding a lump sum or sending the account to collections, the practice documents a formal agreement with manageable monthly installments. Every payment plan is a documented agreement that specifies the total balance, the monthly amount the patient can reasonably afford, the payment dates, and exactly what happens if a payment is missed, typically a call and a chance to renegotiate before collections. In practice, the CMA reviews the balance, asks what the patient can afford each month, agrees on an amount that clears the balance within a set period, and prepares a signed written plan. The billing system then schedules recurring statements rather than aggressive collection notices. Payment plans are often confused with related tools. A sliding fee scale reduces the underlying charge based on income. Charity care writes off the balance for documented hardship. Medical credit cards involve third-party lenders and may add interest. Payment plans are the in-house interest-free installment option practices offer first. When you see phrases like cannot pay in full, written agreement, or reasonable monthly amounts, the answer points to a payment plan, demanding cash, refusing discussion, or going straight to collections all fail both the patient and the practice. Question 38. A patient sues a clinic, alleging that the provider failed to follow the standard of care, that the patient suffered harm, that the provider had a duty, and that the breach caused the harm. The CMAA recognizes the elements being claimed. Which legal doctrine is being invoked? Your options are A. Battery without consent, B. Negligence with 4 elements, C. False imprisonment by staff, D. Breach of insurance contract. Which would you go with? Lock it in before the reveal. The correct answer is B. Negligence with 4 elements. B is correct because negligence requires the plaintiff to show duty, dereliction or breach, damages, and direct cause, often called the 4 Ds, and malpractice is negligence by a professional measured against the relevant specialty standard. A is wrong because battery is unwanted intentional touching, which would apply to a procedure performed without consent rather than to a failure to follow the standard of care that this scenario actually describes. C is wrong because false imprisonment involves restricting a patient's freedom to leave without legal grounds, which is a different tort from the standard of care breach the patient is alleging in this complaint. D is wrong because breach of insurance contract concerns disputes between insurer and insured, rather than the patient's claim that a clinician's care fell below the standard expected of a reasonable practitioner here. Negligence is the legal doctrine that lets a patient recover damages when a provider fails to meet the standard of care and that failure causes harm. Understanding its 4-part structure is essential for recognizing it on the exam. The 4 elements, as called the 4 Ds, are duty, dereliction, damages, and direct cause. Every single element must be established by the plaintiff. A provider who meets the standard of care has a strong defense even when the outcome is poor, because not every bad outcome is negligence. In litigation, expert witnesses testify on what the standard of care required. Factual evidence shows what happened, and documentation, including progress notes, consent forms, and incident reports, plays a central role for both sides. Strong documentation supports the defense. Gaps often support the plaintiff. Exam distractors include battery, which involves unwanted intentional touching when consent is absent, false imprisonment, which means unlawfully restricting a patient's freedom, and breach of insurance contract. A payer dispute unrelated to patient care. When a stem lists duty, breach, damages, and direct cause, the answer is negligence. Whenever a question stem references duty, dereliction, damages, and direct cause, or mention standard of care and malpractice, that is the negligence doctrine. Spot all 4 Ds together and you have your answer. Question 39. A nurse complains that a chronically late provider keeps the team waiting and morale is suffering. The CMAA suggests an approach that uses a clear I statement, names the impact, and proposes a meeting. Which communication style does the suggested approach best illustrate for the team? Your options are A. Assertive style with clarity. B. Aggressive style with blame. C. Passive avoidance approach. D. Passive-aggressive sarcasm. Don't overthink it. Which one feels right? The correct answer is A. Assertive style with clarity. A is correct because assertive communication uses clear I statements, names a specific impact, and proposes a path forward, which respects the listener and the speaker while keeping the focus on the underlying issue rather than personality. B is wrong because an aggressive style would dominate, blame, or use absolutes like always or never, which provokes defensiveness and damages the relationship rather than resolving the underlying scheduling problem in a productive manner. C is wrong because a passive style would avoid raising the concern at all, allowing the issue to fester and the team's morale to erode further, which fails to protect either the staff or the patients. D is wrong because passive-aggressive communication outwardly agrees while resisting indirectly through sarcasm or silent treatment, an approach that erodes trust and complicates problem-solving rather than supporting clear shared improvement. Assertive communication is the recommended style for workplace concerns because it solves problems while protecting relationships. Unlike the other 3 styles, it combines clarity with respect in a structured, repeatable pattern. The 4 styles are assertive, aggressive, passive, and passive-aggressive. Aggressive communication produces defensiveness and damages trust. Passive communication lets issues fester. Passive-aggressive communication erodes relationships slowly through sarcasm or missed deadlines. Every assertive exchange follows 3 moves. Name the specific behavior with concrete examples. Use an ownership statement to describe the impact on you. And end by proposing a path forward, giving both parties something concrete to act on. In practice, the assertive speaker chooses a private, calm setting. The opening names the behavior, the middle owns the impact, and the close proposes a meeting. So the listener receives a clear concern, no personal attack, and a specific next step rather than a vague complaint. When a STEM includes an ownership statement, names a specific impact, and proposes a meeting, it is signaling assertive communication. Raised voice and blame signal aggressive, avoidance signals passive, sarcasm and outward agreement signal passive-aggressive. Question 40. A patient becomes loud, accuses staff of being lazy, and clenches his fists. The CMAA wants to de-escalate without retreating into power language or threatening removal. Which combination of techniques best fits accepted de-escalation practice for this kind of moment at the front desk in the lobby? Your options are A. Match volume, use power language. B. Turn back, ignore the complaint. C. Lower voice, validate, offer choices. D. Threaten removal, demand silence. Got a guess? Lock it in? The correct answer is C. Lower voice, validate, offer choices. C is correct because lowering voice, validating the feeling, using the patient's name, offering small choices, and setting respectful limits while keeping an exit route in mind are core de-escalation techniques during a heated front desk interaction. A is wrong because matching volume and using power language such as you have to, or policy, says typically escalates rather than calms the situation, which is the opposite of what the de-escalation framework recommends. B is wrong because turning the back on an escalated patient is unsafe and can be perceived as dismissive, which is why de-escalation training emphasizes keeping the patient in view and maintaining an unblocked exit path. D is wrong because threatening removal and demanding silence relies on power and shame to compel behavior, which often inflames rather than calms the patient in a public space and ignores recognized de-escalation practice. De-escalation is a set of techniques for reducing emotional intensity in a tense interaction, without using power language, threats, or confrontation. Understanding why each technique works helps you apply them correctly and recognize them on the exam. There are 5 core techniques. Lowering your voice prompts the other person to unconsciously mirror that calm. Validating the feeling doesn't mean agreeing with the behavior. It means acknowledging the emotion. Using the name, offering a choice, and setting a respectful limit each address a different psychological pressure point driving the escalation. In practice, the sequence unfolds deliberately. The staff member slows breathing, lowers their voice, and opens with a validation statement. Something like, "That kind of wait is genuinely frustrating." The next move offers a small choice, giving the patient something to engage with rather than fight against. Throughout, the staff member keeps an exit path clear. Exam questions are built around this contrast. Correct answers combine lowering voice, validation, and an offer of choice or limit. Distractors describe matching volume, using power language, turning your back, or demanding silence. Each of these escalates rather than de-escalates, making them easy to eliminate once you know the framework. Front desk de-escalation is the everyday foundational layer beneath workplace violence response, grievance handling, and crisis intervention. When you see signal phrases like lower voice, validate, use the name, or offer choices, you're looking at the de-escalation framework, and that's your answer. Question 41. A clinical lead identifies suspected child abuse during an exam. The CMAA learns that the report will go to a state agency under mandatory reporting laws and that the reporter is protected from civil liability for good faith reports. Which agency best fits the destination for this kind of report? Your options are A. FDA MedWatch Program, B. OSHA Enforcement Office, C. Federal Trade Commission, D. State Child Protective Services. Which one is it? Pause the video if you need more time. The correct answer is D. State Child Protective Services. D is correct because suspected child abuse and neglect are reported to State Child Protective Services, with all healthcare personnel mandated as reporters and good faith immunity from civil liability when reports are made in good faith. A is wrong because FDA MedWatch receives reports of adverse drug events and device problems, which is unrelated to suspected child abuse and neglect that goes to State Child Protective Services under state mandatory reporting laws. B is wrong because OSHA enforcement focuses on workplace safety standards rather than child welfare, which is the responsibility of State Child Protective Services under mandatory reporting laws across the various U.S. states. C is wrong because the Federal Trade Commission addresses consumer protection and antitrust issues rather than child welfare, which is the responsibility of State Child Protective Services under mandatory reporting laws. When a healthcare professional suspects child abuse or neglect, the law doesn't wait for proof. Mandatory reporting laws require action based on suspicion alone, and the destination is always State Child Protective Services. The framework has 4 defining features. Suspicion alone is enough to trigger the duty. Good faith immunity removes the fear of legal backlash. Reports are directed to state CPS exclusively, and the state agency, not the clinician, carries out the investigation. In practice, the entire care team plays a role. The clinician surfaces the concern. The CMAA supports logistics and documentation, and the designated liaison contacts the state CPS hotline. Patient confidentiality rules accommodate this because the law itself authorizes the disclosure. Exam distractors often substitute agencies with unrelated mandates. FDA MedWatch handles drug and device adverse events. OSHA covers workplace safety. The FTC addresses consumer protection and antitrust. None of these handle child welfare. Only state CPS does. The reporter's role is to surface the concern, not to investigate or confirm. When signs of possible child abuse appear, State Child Protective Services is always the right destination, and good faith immunity supports the team in making that call. Question 42. An operative report uses the unusual term cardiomyopathy on the diagnostic line. The CMAA must read the report aloud during a clinical huddle and decode the term using its three-word parts before continuing. Which decoded meaning best fits this combined term as written? Your options are A. Disease of heart muscle, B. Inflammation of joint cartilage, C. Bleeding into a brain ventricle, D. Hardening of small artery walls. Take a second. Which answer would you pick? The correct answer is A. Disease of heart muscle. A is correct because cardiomyopathy combines cardio for heart, myo for muscle, and pathy meaning disease. So the term describes disease of the heart muscle, which often presents with reduced pumping function or arrhythmia in patients. B is wrong because inflammation of joint cartilage would use roots like arthro plus chondro plus ETEs, none of which match the cardio, mu, and pathy components present in the term being decoded today. C is wrong because bleeding into a brain ventricle uses different roots such as encephalo and reg. The cardio, myo, and pathy components in the report term refer to heart muscle disease instead of intracranial bleeding. D is wrong because hardening of small artery walls would be arteriolosclerosis, formed from arteriolo plus sclerosis, neither of which corresponds to the cardio, myo, and pathy roots that build the term written in the report. Cardiomyopathy is a compound medical term built from three distinct word parts, each carrying its own meaning. Understanding how these parts work together is the key to decoding dozens of related cardiac and muscle terms. Cardio means heart, myo means muscle, and pathy means disease. Combined, cardiomyopathy simply translates to disease of the heart muscle. Knowing these three parts lets you decode the term instantly wherever it appears in a clinical report. Cardiomyopathy affects the myocardium and the muscular wall of the heart. Depending on the subtype, the muscle may become dilated and weakened, hypertrophic and thickened, or restrictive and stiff, each altering the heart's pumping function. The same word parts recombine across many terms. Cardiomegaly pairs cardio with megaly for enlarged heart. Myopathy pairs my with pathy for general muscle disease. Pathology pairs path with ology for the study of disease. Recognizing the parts unlocks the whole family of terms. The standard decoding strategy is to identify the suffix first, then the roots. For cardiomyopathy, pathy signals disease, myo signals muscle, and cardio signals heart. Master these parts and any compound term built from them becomes readable on sight. Question 43. A compliance officer reviews release of records to an outside party and notes that psychotherapy notes need a separate authorization from the rest of the chart. The CMAA recognizes the rule. Which underlying principle best explains the separate handling for these specific notes in this scenario? Your options are A. Combined release for any provider notes, B. No protection for any patient notes, C. Heightened protection for psychotherapy notes, D. Notes always go with billing data. Before I reveal it, which one do you think is right? The correct answer is C. Heightened protection for psychotherapy notes. C is correct because psychotherapy notes receive heightened protection under HIPAA and require a separate authorization for release, distinct from the general chart, except in narrow situations such as defending against legal action by the patient. A is wrong because combining release of psychotherapy notes with the rest of the chart fails the separate authorization requirement and risks an improper disclosure of information given heightened protection by the privacy rule. B is wrong because no protection for patient notes is contrary to the heightened protection rule for psychotherapy notes, which exists precisely because of the sensitivity of mental health treatment communications between provider and patient. D is wrong because psychotherapy notes do not automatically travel with billing data. Coding for billing relies on different documentation, while psychotherapy notes are kept separately and require their own authorization for release. Under HIPAA's privacy rule, psychotherapy notes receive heightened protection that goes beyond the standard chart framework. This isn't just a stricter version of the usual rules. Now, it's an entirely separate authorization requirement. HIPAA defines psychotherapy notes narrowly. They are the clinician's personal analysis of a counseling session stored separately. Diagnoses, medications, and treatment plans live in the general chart and are governed by the standard authorization framework, even when they relate to mental health care. Operationally, psychotherapy notes are stored in a separate location, physically or in a separately controlled section of the EHR. A release request that authorizes the general chart does not automatically include psychotherapy notes. A second specific authorization is required for those notes alone. The exceptions to this separate authorization rule are narrow. The originator may use notes for treatment, for training, or to defend against a legal action brought by the patient. Outside these situations, the heightened protection holds. The core principle is simple. Psychotherapy notes are categorically separate from the general chart and always require their own authorization. The therapeutic relationship depends on that confidentiality, and HIPAA enforces it structurally. Question 44. An active employee aged 68 has Medicare and an employer plan from a large company. The CMAA recalls the Medicare coordination rule. Which rule best fits the order of payment for this patient under Medicare coordination guidance for the encounter? Your options are A. Medicare primary, employer secondary. B. Employer plan primary, Medicare secondary. C. Both bill at the same time always. D. Patient pays cash with no claim. What's your answer? Commit to one before I continue. The correct answer is B. Employer plan primary, Medicare secondary. B is correct because for Medicare, due to age and active employment with an employer of 20 or more employees, the employer plan is primary and Medicare is secondary, reflecting Medicare's coordination of benefits framework for active workers. A is wrong because Medicare primary with employer secondary applies in different scenarios such as smaller employers, retirees, or specific situations, but not to the active employment large employer case described in this scenario. C is wrong because submitting claims to both plans simultaneously without coordination conflicts with the Medicare coordination framework, which establishes a primary-secondary order rather than parallel processing of identical claim transactions. D is wrong because paying cash with no claim ignores the patient's insurance entirely, which conflicts with the coordination of benefits framework and the assignment of benefits the patient typically signs at registration. When a patient has both Medicare and an employer health plan, specific rules determine which plan pays first. This framework is called Coordination of Benefits, or COB, and it exists because Medicare was designed to work alongside employer coverage, not replace it. The COB order depends on three factors: why the patient has Medicare, the size of the employer, and whether the patient is an active worker or retiree. These factors together determine which plan is primary and which is secondary. For an active worker with age-based Medicare at a large employer, the employer plan pays first as primary. Medicare adjudicates second, covering costs the primary did not pay. The patient then receives coordinated explanation of benefit statements from both plans. At registration, the CMAA collects both insurance cards and verifies eligibility on each plan. The claim goes first to the employer plan, and once that remittance arrives, the secondary claim is submitted to Medicare with the primary payment information attached, so Medicare can adjudicate the remainder. Different Medicare eligibility paths produce different TOB outcomes. Age-based Medicare with a large employer means the employer plan is primary, while retirees and small employer situations typically make Medicare primary. ESRD has its own special rules, and simultaneous billing is never the correct answer under any COBE scenario. Question 45. A practice runs an aging report that buckets accounts receivable by 0 to 30, 31 to 60, 61 to 90, 91 to 120, and beyond. Which underlying purpose best fits these buckets in operations review at the practice today? Your options are A. Track patient lunch preferences, B. Track parking lot turnover times, C. Track new staff onboarding times, D. Track outstanding receivables by age. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Track outstanding receivables by age. D is correct because aging buckets track outstanding receivables by age, separately for insurance and patient receivables, so the practice can investigate aging accounts, work denials, and pursue patient balances before they become uncollectible over time. A is wrong because lunch preferences are unrelated to receivables aging, which focuses on the time accounts have been outstanding rather than employee meal break taste during the work week at the practice. B is wrong because parking lot turnover is unrelated to receivables aging, which focuses on outstanding accounts rather than the physical turnover of vehicles in the practice's parking facility during the day. C is wrong because new staff onboarding times are unrelated to receivables aging, which focuses on outstanding accounts rather than the duration of employee orientation at the practice during the year. The Accounts Receivable Aging Report is the central operational tool that organizes collection work across the revenue cycle. It groups outstanding balances by how long they have been unpaid, so the billing team knows exactly where to focus its efforts. Balances are sorted into 5 standard buckets: 0 to 30, 31 to 60, 61 to 90, 91 to 120, and beyond 120 days. Insurance receivables and patient receivables are tracked separately because their collection dynamics differ. The reason these buckets matter is that the probability of collecting an account falls as it ages. A claim under 30 days is a normal processing, but by 90 days something has stalled. Past 120 days, especially near timely filing limits, the account is at serious risk of being uncollectible. In practice, the billing supervisor reviews the aging report weekly or monthly. Higher age insurance accounts receive denial follow-up, resubmission, or appeal. Patient accounts get statements, calls, and payment plan offers. Accounts that exhaust internal efforts move to external collections or write-off. Do not confuse the aging report with days in AR, which is a single summary metric, or with denial management and bad debt write-off policies, which are adjacent activities. The aging report is the operational map that drives all of them. Question 46. A CMAA hears a patient describe a sore throat for 3 days, fever to 101 and no cough. To confirm understanding before moving on, the CMAA repeats the items back and asks if anything was missed. Which interviewing technique does this approach most clearly illustrate? Your options are A. Summarizing to confirm and transition, B. Leading the patient toward bias, C. Probing for one specific detail, D. Reflecting only emotional tone. Which would you go with? Lock it in before the reveal. The correct answer is A. Summarizing to confirm and transition. A is correct because summarizing consolidates what has been said and confirms accuracy before transitioning to the next portion of intake, which catches missed items and helps both the patient and the CMAA stay on the same page. B is wrong because leading the patient toward bias would suggest an answer and distort information. The technique here repeats back what was already said rather than steering the patient toward a particular conclusion. C is wrong because probing for one specific detail digs into a single point such as nighttime pain rather than consolidating an entire set of items. So the deepening behavior does not match the summarizing scenario. D is wrong because reflecting only emotional tone restates feelings to validate the patient, which is different from consolidating factual content like duration, fever level, and the absence of cough in this case. Summarizing is a specific interviewing technique where the listener consolidates everything the speaker has shared and reflects it back before moving on. It's more than just repeating. It's a structured pause that serves several purposes at once. A well-placed summary does 4 things. It confirms accuracy, invites the speaker to correct anything missed, organizes the key details, and signals that you're moving to a new phase of the conversation. Imagine a patient who has shared a sore throat for 3 days, a fever to 101, and no cough. The CMAA summarizes those points and asks if anything was missed, and the patient adds that her ear has been hurting. That detail would otherwise have been lost. Exam questions often test whether you can tell summarizing apart from similar techniques. Reflective listening restates feelings. Open-ended questions invite elaboration. Closed-ended questions seek a specific answer. Summarizing is the consolidation move, facts, confirmation, and transition. When a STEM describes a clinician who repeats items back and asks whether anything was missed before moving on, that's summarizing. Those signal phrases, consolidates, confirms accuracy, transitions, point directly to this technique. Question 47. A patient asks whether he is allowed to refuse a routine treatment. The CMAA wants to respect the patient's autonomy without stepping into clinical territory. Which response best fits accepted practice while reflecting the CMAA's role and the patient's right to make care decisions independently? Your options are A. Refuse to discuss, end conversation. B. Explain that providers will overrule. C. Acknowledge right, involve clinician. D. Sign a refusal form for the patient. Don't overthink it. Which one feels right? The correct answer is C. Acknowledge right, involve clinician. C is correct because acknowledging the patient's right to refuse and looping in the clinician to discuss risks, alternatives, and documentation respects autonomy, stays within the CMAA's scope, and supports a clean handoff to the clinical team. A is wrong because refusing to discuss the question entirely abandons a patient who is exercising autonomy, weakens trust, and leaves the clinical team without a record that the question was raised at all today. B is wrong because explaining that providers will overrule the patient is incorrect, since competent adults retain the right to refuse treatment, and the role of the clinician is to inform rather than override. D is wrong because signing a refusal form for the patient is a legal misstep, since refusal forms must be signed by the patient or appropriate surrogate after the clinician has discussed the relevant information. Patient autonomy means competent adults have the legal and ethical right to refuse any recommended treatment, not just to accept it. This right is as protected as informed consent, and the entire care team must respect it. When a patient raises the question of refusing treatment, the CMA has 3 responsibilities: acknowledge the right, signal that the clinician will follow up, and route the inquiry, nothing more. The CMAA never signs refusal forms, never shuts down the conversation, and never tells the patient that providers will overrule the decision. In practice, the process is a clean handoff. The CMAA acknowledges autonomy and routes the patient to the clinician, who holds the structured discussion about risks, alternatives, and consequences. If the patient still declines, the patient, not the CMA, signs the refusal form, and the chart documents everything. Autonomy connects to several adjacent concepts. Informed consent is the affirmative counterpart agreement after a structured discussion. Advanced directives capture preferences when a patient can no longer communicate. Surrogate decision-making applies when the patient lacks competence. Keeping these distinct on the exam prevents distractor traps. The exam tests role boundaries. The CMAA acknowledges autonomy and loops in the clinician. Every other action either overreaches or misrepresents the framework. Acknowledge, route, and stay in scope. Question 48. A note describes that a patient has hyperglycemia and hypertension on the active problem list, but the family asks for a plain language translation. The CMAA decodes the prefixes hyper and hypo as a teaching moment. Which pair of meanings best fits the prefixes in this context? Your options are: A. Hyper means slow, hypo means fast. B. Hyper means above, hypo below. C. Hyper means inflamed, hypo means cut. D. Hyper means bone, hypo means muscle. Got a guess? Lock it in. The correct answer is B. Hyper means above, hypo below. B is correct because hyper means above normal or excessive, and hypo means below or deficient. So hyperglycemia is high blood glucose and hypotension is low blood pressure, while hypertension itself means high blood pressure overall. A is wrong because Touchy and Brady relate to fast and slow rates, not the hyper and hypo prefixes, which describe levels above or below normal rather than speed or rate of bodily activity. C is wrong because the suffix at describes inflammation and the suffix tomi describes cutting into. Neither concept is captured by the hyper and hypo prefixes in scenarios like hyperglycemia or hypotension. D is wrong because bone and muscle correspond to the roots osteo and myo, which describe anatomic structures rather than the level-based hyper and hypo prefixes used in the patient's problem list terms. When reading medical terminology, 2 of the most important prefixes you'll encounter are hyper and hypo. Understanding them unlocks dozens of clinical terms instantly, because the same root word produces completely opposite conditions depending on which prefix is attached. Hyper means above, excessive, or increased. Hypo means below, deficient, or decreased. Critically, these are level prefixes only. They are not about speed, which belongs to Touchy and Brady, and not about anatomy or inflammation. The prefix pair appears across many common clinical terms. Hyperglycemia and hypoglycemia describe opposite blood sugar levels. Hypertension and hypertension describe opposite blood pressure levels. Hyperthyroidism and hypothyroidism describe an overactive versus underactive thyroid. The decoding strategy is always the same. Identify the prefix first because it sets the level. Then apply the root and suffix. For hypertension, hyper sets high. Tens refers to pressure and cyan completes the noun. Swap hyper for hypo and everything else stays the same, giving you the opposite condition. Exam distractors often swap hyper and hypo with these unrelated terms. Tacky and Brady describe rate, not level. Itis and tomi are suffixes about inflammation and cutting. Osteo and myo are structural roots for bone and muscle. Recognizing these as separate families keeps your prefix decoding accurate. Question 49. A practice receives an OCR investigation letter following a complaint. The compliance officer prepares the practice to cooperate, document fully, and consider mitigating factors. Which combination of factors best fits accepted enforcement considerations during such an investigation by the Federal Office for Civil Rights? Your options are A. Marketing volume, vacation policy. B. Color scheme, logo, signage. C. Lunch hours, parking lot size. D. Harm, history, finance, cooperation. Which one is it? Pause the video if you need more time. The correct answer is D. Harm, history, finance, cooperation. D is correct because OCR considers the nature and extent of harm, the entity's history of compliance, financial condition, and cooperation in the investigation when determining penalties, alongside the specific facts of the alleged violation under review. A is wrong because marketing volume and vacation policy are unrelated to OCR enforcement criteria, which focus on the nature of the violation and the entity's compliance posture rather than operational marketing details. B is wrong because color scheme, logo, and signage have no role in enforcement weighting under OCR criteria, which focuses on harm, history, finances, and cooperation rather than visual branding details for the practice. C is wrong because lunch hours and parking lot size are operational facts unrelated to OCR's enforcement considerations, which focus on the violation itself and the entity's compliance record, rather than physical workplace logistics. When OCR investigates a HIPAA violation, it doesn't apply a fixed formula to determine penalties. Instead, it weighs 4 specific factors that shape the outcome of every enforcement case. The 4 factors are the nature and extent of harm caused, the entity's history of compliance, the entity's financial condition, and the degree of cooperation with the investigation. Every penalty determination is shaped by how these 4 elements combine in a specific case. In practice, an entity under investigation supports its position by producing organized documentation, risk assessments, training records, and corrective action plans, and by engaging transparently with investigators throughout the process. An entity that self-reports, cooperates fully, and implements meaningful corrective action typically faces a less punitive outcome. An entity with prior violations, limited cooperation, and documented harm faces a much steeper calculation. The financial condition factor also recognizes that penalties threatening patient care may not serve the public interest. These 4 factors, harm, history, financial condition, and cooperation, are the documented framework OCR applies. Distractors like marketing volume, signage, or parking policy have no role in HIPAA enforcement weighting whatsoever. Question 50. An 837P transaction carries a professional claim, while an 837I carries an institutional claim. The CMAA recognizes the underlying difference between these 2 HIPAA transactions. Which contrast best fits the difference in everyday billing language at the practice in this scenario today? Your options are A. Inpatient versus outpatient diagnosis only. B. Professional versus institutional claims transmission. C. Pediatric versus adult treatments only. D. Telehealth versus in-person modalities. Take a second. Which answer would you pick? The correct answer is B. Professional versus institutional claims transmission. B is correct because the 837P transaction transmits professional claims such as physician services, while 837I transmits institutional claims for hospitals, with 837D used for dental services in the family. A is wrong because the contrast is professional versus institutional claims rather than inpatient versus outpatient diagnoses, which is a different distinction tracked through codes and coverage rather than the claim transaction format itself. C is wrong because the contrast is professional versus institutional claims rather than pediatric versus adult treatments, which is unrelated to the claim transaction format and is tracked through other parts of the claim submission. D is wrong because the contrast is professional versus institutional claims rather than telehealth versus in-person modalities, which is captured through modifiers and place of service codes rather than the underlying claim transaction format itself. Within the HIPAA electronic data interchange standards, the 837 transaction family handles claim submission, but not as a single universal format. 3 distinct 837 formats exist because professional and institutional billing have fundamentally different data needs. The professional 837 covers physician services and outpatient visits. The institutional 837 covers hospital and facility billed care. The dental 837 covers dental claims. All 3 share a common technical envelope but carry format-specific data structures. A professional claim captures the rendering provider, place of service, and diagnosis codes supporting the services. An institutional claim instead captures revenue codes, patient stay information, and type of bill. Facility-specific elements a single combined format could not handle cleanly for both sides. In practice, the billing system automatically generates the correct 837 format based on claim type, and the clearinghouse routes it to the appropriate payer queue. The format distinction is invisible at the front desk, but determines exactly which data elements must be captured during registration and the encounter to produce a valid claim. When an exam question asks about 837 formats, the key distinction is always professional versus institutional claim transmission, not inpatient versus outpatient diagnosis, not patient age, and not care modality. Those are unrelated dimensions that exam writers use as distractors.
You have reached the end of our study video for the free complete exam preparation. Visit our website link in the description, and you can find thousands of practice questions and comprehensive study guides on our website. Thank you for studying with us today. See you in the next video.